No, David. Come on, teacher. There's no teacher.
Hello, Annette.
Hello, good morning.
Morning, we are with you.
Admin, please mute all the microphones. Mute all the microphones except you. Good morning, everyone. My name is Caleb Aldo, and I welcome you all to this year's virtual panel discussion. I'm the Programs and Strategic Communications Officer at Sickle Cell Foundation Nigeria, and today we're excited to have people joining us from around the world, from Egypt, Tanzania, Kenya, the United States of America, United Kingdom, Nigeria. You're all welcome, and I trust that we'll have an incredible time today. I want to just pass across a little housekeeping announcement before we welcome our National Director, Dr. Annette Akinshete, to take over from me. So please, throughout the session, make sure that your microphone is muted and your video is muted as well, so that we don't interrupt the session. And do well to also stay in a quiet environment for our speakers, so that we don't have noise interference. And that will be all for now. And our moderator would guide us through every step of the session, so we are abreast with what will be coming up next at all times. Thank you so much for joining us once again. I'll be handing over to our National Director now. Thank you.
So we're getting a little more accustomed to this. I was muted and talking. So I'm saying good morning, everyone. Good afternoon, good evening, depending on where you are across the globe. We are really happy to have you all. My job is to welcome everyone to this virtual panel discussion. I think it's clear that technology has helped us come together from across the globe, and it's really something we're very grateful for. So I have a prepared address, introducing myself first. Very distinguished ladies and gentlemen. We have in our midst the immediate past First Lady of Delta State. So I must recognize her, as we do, Dame Edith Okon. All other duly observed. I am Dr. Annette Akinshete. I'm a medical doctor, and I'm a consultant public health physician and the National Director and CEO of Sickle Cell Foundation Nigeria. Permit me to commence with a few words about Sickle Cell Foundation Nigeria. Sickle Cell Foundation Nigeria is a form of sickle cell NGO and a major stakeholder in the sickle cell space. The foundation has, over the past 30 years, been actively advocating for the sickle cell cause and working with government and other entities in a number of public-private partnerships. Our work spans the entire spectrum of sickle cell programming: capacity building, advocacy, research, prevention, treatment, care, and support, and now cure, because we have indeed opened up the Center for Bone Marrow Transplantation. In line with the WHO recommendation, Sickle Cell Foundation Nigeria established the National Sickle Cell Center here in Lagos as far back as 2007. This is the first of its kind in all of Africa. And in 2022, our state-of-the-art bone marrow transplant center was formally commissioned in Lagos, a partnership between the foundation and University of Lagos Teaching Hospital, that's LUTH, and international partners. On behalf of the board and management of the foundation, I warmly welcome everyone to this virtual panel discussion. It's organized to commemorate the 2025 World Sickle Cell Day, which, as you know, is celebrated every June 19th. Today is June 12th, but the entire month of June, we're celebrating World Sickle Cell Day, or month, if you like. This is as designated by the United Nations, and it's to raise awareness about all aspects of sickle cell disorder. And we're calling on governments. It's a time to call on private sector. It's a time to call on international organizations, to call on all other actors, all stakeholders, and urge everyone to take notice and take action. Distinguished ladies and gentlemen, like I said, thanks to technology, we can gather here from all parts of the world, bridging space and time to address sickle cell disorder with a theme. Today's theme is topical: access to new therapies, hope or hype. Access to new therapies, hope or hype. Exploring bone marrow transplants, gene therapies, and accessibility in low resource settings. The theme is indeed timely, as breakthroughs in sickle cell therapies are making headlines, alongside growing concerns about equity, about access, and justice in the global health space. So this indeed is a seminal moment. I'm trying to take it in, and is one of convergence, a transcontinental discourse where innovation meets equity and where silence is disrupted by the collective resonance of commitment, urgency, and truth. You see, I'm waxing poetic because indeed for me, this is something very close to my heart. We gather today not merely to dialogue, but to catalyze transformation. We're not here to echo what has been reiterated in medical journals or rehearsed global declarations that have long lost their bite. We are here to stir, to re-image, to reimagine, and most crucially, to resolve, to take action. It was Napoleon Bonaparte who said, "The world suffers a lot, not because of the violence of bad people, but because of the silence of good people." Today is one day, one such day, when we refuse to be silenced. As a physician who has traversed the corridors of clinical practice, public health leadership, and policy dialogue for several decades, I have listened, not simply with a stethoscope, but with tools of the mind and also with intent. And what I hear from the global sickle cell community, not only Nigeria, across the world, is this: that enough is enough. Enough of fragmented responses, enough of policy apathy, enough of barriers to treatment and to care, particularly those that are coming up now. Distinguished ladies and gentlemen, sickle cell disorder is not rare. It is not a footnote in the narrative of global health. Sickle cell disorder is the most common inherited blood disorder in the world. We need to accord it that respect. It diminishes quality of life and is responsible for many untimely deaths, a number of which could be prevented with appropriate care. We speak today not just of therapies, but of justice, because curative therapies without equity will be like oxygen in a room that is sealed. It's present, but is inaccessible. Again, it was Dr. Martin Luther King Jr. who said that of all the forms of inequality, injustice in health is the most shocking and inhuman. Ladies and gentlemen, gene therapies and stem cell transplants, these are rewriting the biology of possibility. What are the things that are possible for us in this space? But what good are medical innovations if they remain inaccessible, never reaching those who need it around the world, here in Akure, across from us in Accra, Kampala, or in Kinshasa? You notice these are all towns that are in sub-Saharan Africa. And these are places that we talk about when we say low-income settings. Today, we are truly privileged to have a very distinguished keynote speaker and what I have termed a powerhouse panel of discussants who will help us unravel what works for all and not just wonders for a few. They will dissect the value in building towers of genomic excellence on foundations of weak health systems that leak lives and health through many cracks. So let us rethink the pyramid of care Imagine it, a pyramid of care. At its base, you have prevention, education, early diagnosis, and prompt, effective treatment. These are not simply basic interventions. These are life-saving fundamentals. And that's with the ABCs of resuscitation, which we know, ABCs of resuscitation, you cannot intubate a system whose airways have not been cleared. I'm asking us to be imaginative a little and think about it that way. I'm finishing now. At its apex, the apex of this pyramid, we have the therapies, these new therapies, and the cures. So let us query, can the innovations be democratized while we scale up the basic package? I feel that both of them must advance together. Otherwise, our health systems will collapse under inequity. Distinguished ladies and gentlemen, let us listen to the sages we have gathered here today. We are blessed to have them today with us as they consider, one, the recent breakthroughs in gene therapy, stem cell transplantation, and even more. Two, what hope these therapies represent for people living with sickle cell disorder. Three, the harsh reality of limited access in low and middle income countries that may dash any hope. Four, the moral and global health imperative that ensures equitable access, and even more. So as we probe the present and we forecast the future, let us pause, think, internalize, and reflect on the thought that equity without innovation is inadequate. Equity without innovation is inadequate. But also innovation without equity is immoral. Innovation without equity is immoral. These are thoughts we should reflect, mull over while listening to our sages. So welcome to this historic conversation. Thank you all for your kind attention. Again, to our sages who are listening, thank you very much for being here with us today. I'm Annette Akinshete. Thank you. Okay, I think I'm to go on and welcome the chairman of Sickle Cell Foundation Nigeria to deliver his remarks. That is to declare this panel discussion open. Am I to do that, Caleb? Am I to go?
Yes, ma'am. Kindly proceed.
Thank you very much. So I'll introduce our chairman, the chairman of Sickle Cell Foundation Nigeria. And this is none other than Chief Tunde J. Afolabi, MFR. Chief Tunde J. Afolabi is the chairman of the board of directors at Sickle Cell Foundation Nigeria. He was the founding managing director and CEO of AMNI International Petroleum Development. And now he's the chairman and CEO of that same company. He received his BA in geology in 1973 from Franklin and Marshall College, Lancaster, Pennsylvania, USA, and the master's in geology in 1975 from Tulane University, New Orleans, Louisiana, USA. He started his career with Texaco Incorporated in New Orleans, Louisiana in 1974, and continued with Mobil Incorporated in Dallas. He is a professional geologist with over 40 years of oil and gas exploration and production experience from international and independent oil and gas companies. He is a member of the American Association of Petroleum Geologists, AAPG, a past president of the Nigerian Association of Petroleum Explorationists, NAPE, and a council member of the Nigerian Association of Indigenous Production and Exploration Companies, NIPEC. He was conferred with the Doctor of Technology honoris causa by Ladoke Akintola University, Womosho, Osun State, Nigeria. This was in 2009. And also the Doctor of Geology honoris causa, Ajayi Crowther University in Nigeria, or Oyo State, Nigeria, in 2017. He's a man of many parts, really. This just is a succinct summary of who he is. He's the chairman of our board. He's interested so much in sickle cell. He's followed this cause for many years. I wish he was here, but he's not able to be here. However, he has asked very kindly that he be represented here today, and he is, I see her, by none other than Mrs. Uwa Ohiku, the eclectic Uwa Ohiku. Very much, Uwa is a member of the board of Sickle Cell Foundation Nigeria, and is a senior partner in the very top law firm called Jackson, Eti, and Edu. She's the mother of a growing sickle cell warrior who has accessed bone marrow transplantation and is living very well today. Over to you, Uwa. The floor is yours.
Good morning. Thank you, Annette. Good morning, everyone. I hope you can hear me. Annette, can you hear me?
Yes, loud and clear.
Okay. Thank you all so much for, and I think I want to thank the chairman of Sickle Cell Foundation for asking me to step into these huge shoes of his and to give his welcome address. I count it honestly privilege and a great honor. Thank you all so much. So I'm going to go straight into his welcome address. Your Excellency, Dame Mrs. Edith Okowa, founder 05 Initiative and immediate past First Lady of Delta State, representative of the World Health Organization and the United Nations system, esteemed representatives of our distinguished partners, our most distinguished keynote speaker, our illustrious panelists, our courageous sickle cell warriors, champions and their families, dedicated stakeholders from around the world, advocates, caregivers, supporters, friends of the Sickle Cell Foundation of Nigeria, gentlemen of the press. It is my honor and great pleasure to welcome you all to this virtual panel discussion organized by the Sickle Cell Foundation of Nigeria in commemoration of World Sickle Cell Day 2025. Our theme this year, access to new therapies, hope or hype, exploring bone marrow transplants, gene therapies, and accessibility in low resource settings, speaks to a central tension in global healthcare delivery today. This theme underscores the urgent need to bridge the widening gap between scientific breakthroughs and equitable access. While we celebrate the promise of advanced therapies such as bone marrow transplants and gene editing, we must also ask, who benefits? Who is left behind? For people living with sickle cell disease in low resource settings, access to these advancements in medicine must be more than just a distant hope. It must become a shared priority and indeed a reality. And so today's gathering is more than a panel discussion. It is a call to reflection, solidarity, and most importantly, a call to action. Without further ado, I hereby declare this virtual panel session open. Let us all gathered here today listen deeply and with understanding. Let us engage meaningfully and let us commit individually and collectively to solutions that will bring lasting impact. Together, we can and must lead the change towards a future where no one is denied treatment, whether old therapy or new therapy, just because of where they live, what they earn, the circumstances of their birth. Thank you very much, and I wish you a successful and fruitful outing today. Chief Tunde Afolabi, MFR, Chairman, Sickle Cell Foundation of Nigeria, and the date is today, June 12, 2025. Thank you very much.
Thank you so much. Thank you, Uwa, for stepping in for our chairman. And I believe, well, this will be recorded. Our chairman will also be able to listen. And I'm sure he'll be grateful that you did this for him. So very quickly, we'll move to goodwill addresses. Like I was saying, to some of us yesterday, these goodwill addresses are very important. These are persons who are stakeholders that we're working with through the years. Because we cannot work alone. Really, gone are the days when we all worked in silos, everybody did their own thing. So we have to carry all of these persons along, and whatever we're doing, we try and be on the same page. As we say in our own traditional culture, we have a broomstick, you can break it easily. But when you are bunched together, a broom not to stick alone, you cannot break it. So also another analogy that says, when spider webs unite, as thin as they are, they can tie up a lion. That speaks to the beauty of partnerships. So I have here on my list GANSID. GANSID is a global action network for sickle cell and other inherited blood disorders. Global Action Network for sickle cell and other inherited blood disorders. And to give the goodwill address for GANSID today is again none other than Professor Adekunle Adekile. He's the chairman of the board of GANSID. Professor Adekile, please.
Thank you very much, Annette. Good morning, good afternoon, or good evening, wherever we are. And it's my pleasure to be on this call and to felicitate with all of us, especially the global sickle cell disease community. And I really want to commend the Sickle Cell Foundation and the CEO for arranging this marvelous virtual meeting. And I see that there are people on the call from several different parts of the world. And I'm also happy about the theme of the day, looking at how curative therapies and the new therapies can be made available in an equitable way for all. I must say that we made a lot of strides in the sickle cell community in the last few years. And I really want to congratulate the Nigerian sickle cell community for hosting the Global Congress that ended last week. It was a big success in spite of all the different hurdles. It's real kudos to the organizers, and we can all feel proud. Now, while we talk about curative and novel therapies, we need to bear in mind that for a long time to come, the mainstay of management of sickle cell disease is going to be at the primary care level, so that we can reach all the warriors who live in remote and rural areas. And I'm really happy that there are multiple advocacy groups in the country, not only in Nigeria, but in different parts of the world. I want to make a case, however, that there should be a central coalition that unites all these bodies and sees to it that each advocacy group is well educated about the disease, so that they can give true and welcome advice and counseling to their members. Such a coalition is necessary, and we would urge that the different groups are represented at the central coalition so that there will be cohesion. Now, this GANSID stands for the Global Action Network for Sickle Cell Disease and Other Inherited Blood Disorders. And this is deliberate because we know that sickle cell disease, of course, is the most common and the most important of these inherited blood disorders. But there are others. And people who live with all these other disorders need also to have champions, okay? And that's why GANSID brings together these diseases. We have to think of things like thalassemia, bleeding disorders like hemophilia. There are other, blood elements that could also have all kinds of disorders. Therefore, we focus on disease-specific and cross-disease initiatives so that we can all help each other to grow. Okay, and I'm going to share the website for GANSID in the chat, as soon as I finish. But we just want to bring to your notice that GANSID has several initiatives that we can all benefit from as individuals and as advocacy groups. GANSID is now present in 35 countries with more than 80 affiliate members. There's an e-app, educational app on the site that is actually geared towards educating advocacy groups on how to mobilize, how to organize, how to relate to policymakers, and how to raise funds. So that would be quite useful. And we're also going to have educational modules for community health workers, nurses, so that they get to understand sickle cell disease better. So that will always be available. Okay. Now, the one other thing that we do is the mentorship program, so that if you are a clinician working in a remote area, you need guidance, so you can sign up. We have mentors in different parts of the world that will mentor you over a 6-month period, and the mentor will visit you in your site. Okay, and then there are other, initiatives in the pipeline that you will see on the website. So to finish, let me again commend the Sickle Cell Foundation and for putting this together and inviting somebody of the caliber of Professor Makani to address the issue of new therapies and curative therapies. So I wish you all happy deliberation, and at the end of the day, I'm sure we shall all be better informed and better encouraged to carry on the big task of improving the outcomes for those who live with the disease. Thank you so much.
Thank you so much, Professor Adekile. Professor Adekile is someone that is very highly respected. We are very happy that you are here with us this week. And despite, I know you're traveling around for GANSID and other endeavors. God bless you. And might I just add here that there's a timer for the Google addresses. I'm not sure. Okay, is it up there? There's a timer for the Google addresses. Nevertheless, Professor Adekile, I know you mentioned about the importance of a coalition, and in a couple, I think after the next speaker, you'll be hearing from the new chair of the Coalition of Sickle Cell NGOs. That's our attempt to bring together the NGOs in Nigeria in the sickle cell space. But let me go straight now to the Sickle Cell Support Society of Nigeria. And Professor Nodu is unavoidably absent. She's traveled. So she's asked again, none other than the delectable Professor Nora Akinola of Great Ife to step into her. Professor Akinola is the coordinator for the Southwest Zone for Sickle Cell Support Society of Nigeria. Am I right, Professor Nora? Coordinator for Southwest Zone, Professor Nora Akinola of the University of Ife Teaching Hospital, of OAU Teaching Hospital. Professor Nora, please, to give the goodwill address on behalf of Professor Obi Nodu, the chair of Sickle Cell Support Society of Nigeria. Professor Nora, please. Professor Nora is here. I saw her earlier. Professor Akinola, admin, hosts, can you see her? Okay, whilst Professor Nora is getting ready, we'll go straight to, yes, the vibrant Miss Timmy Edwin. Timmy Pro. Timmy Pro is the founder and CEO of
I'm now unmuted.
Okay, there you are. Sorry, now stand by, Timmy.
Sorry.
We have Professor Nora now. Professor Nora is the coordinator of the Southwest Zone of Sickle Cell Support Society of Nigeria. Am I right, Professor?
Correct.
Very good. Like I said, Professor Nora is of the OAU Teaching Hospital. I'm not used to that. I'm still saying University of Ife Teaching Hospital in Ife. That is Great Ife. And I'm not Great Ife, I'm Ibadan.
I had challenges with unmuting. I was not allowed to unmute. That's what happened. So good morning, everyone. Thank you very much, Annette, for the invitation. I'd like to stand on existing protocol. The chairperson of the Sickle Cell Support Society of Nigeria, Professor Obiagelu Nodu, called me from the airport this morning to ask me to give this goodwill message on her behalf, as she cannot connect at this time. I bring special greetings from the Sickle Cell Support Society of Nigeria on the occasion of this year's World Sickle Cell Day of Awareness, holding today. The theme of this year is apt, as it is a continuation of the conversation that permeated the recently concluded Global Sickle Cell Congress 2025 that was hosted by Sickle Cell Support Society Nigeria in Abuja last week. At this meeting, we were informed that to get new treatments across to the level of the stakeholders, it would take 17 years. So which means that for it to be readily available, we will need to probably wait for another 17 years or so. But we also know that the awareness needs to continue, as the southwest zone of Nigeria is one of the high burden zones of the country. And therefore it is pertinent that we continue to increase awareness and educate both healthcare providers and people living with sickle cell disease about the developments in the care and treatment of this disorder, so that we may all be on the same page and no one is left behind. About Sickle Cell Support Society of Nigeria, we are a society that has a national spread, has zonal coordinators, and we have priorities and objectives. We work with stakeholders and members in Nigeria and in diaspora, and with also trusted partners in the government. And with reference to the WHO guidance framework of sickle cell treatment centers and center of excellence in high burden countries, one of the priorities is capacity building, which we do at all levels. And to facilitate this, we have collaborated with other countries in sub-Saharan Africa under SPACO and SADC to produce a standard of care guideline for sickle cell disease in sub-Saharan Africa. And we hope that this will be used across board for the capacity building of all stakeholders. And in addition, we also hope to work with Nigerians in diaspora and with requisite expertise in providing curative treatment in stem cell transplantation, including gene therapy, has been demonstrated by Vellore Medical College in India and Uganda, preparing to follow, and we are preparing to follow suit. The society is calling for greater cohesion, unity among all stakeholders to work closely together to advance basic comprehensive care and cutting-edge treatment for all patients with sickle cell disease. So at this point, I congratulate you, the Sickle Cell Foundation of Nigeria, for this occasion and for commencing bone marrow transplant program in Lagos. May God enable us to improve quality of care and quality of life of people living with sickle cell disease in this environment and indeed in sub-Saharan Africa. For together we can. I wish you successful deliberations on behalf of Professor Nodu. Thank you for the invitation. Congratulations. Thank you.
Thank you so much. Thank you so much, Professor Nora Akiola, for that wonderful goodwill address. And you're right, we'll continue to foster collaboration across all of us advocates and scientific organizations around in the sickle cell space. There's a lot we need to do together. Am I being muted?
Oh, you're audible, ma'am. You're audible. Go ahead.
Okay, thank you. So now I'm going to call back Timmy Edwin. Like I was introducing her earlier, Timmy Edwin is the founder and CEO of Crimson Bow Sickle Cell Initiative, and she's our new chair of the coalition of sickle cell NGOs in Nigeria. They run Indefatigable Timmy Pro.
Thank you. Thank you, Dr. Annette. I'm very grateful for this opportunity. On behalf, I will stand on existing protocols because I know that there are quite a number of important people here. And I would just like to say that, let me just go right into my goodwill message. Distinguished guests, friends, fellow advocates, and champions of the sickle cell community, a very warm welcome to you all. On behalf of the Coalition of Sickle Cell NGOs of Nigeria, I'm delighted to join you in marking World Sickle Cell Day 2025, a day of awareness, reflection, and renewed commitment. Let me begin by saluting our, like I like to call you, our grandparents in the sickle cell fight, Sickle Cell Foundation Nigeria, a true torchbearer in our shared fight against sickle cell disorder. Your leadership, consistency, and passion continue to inspire the entire advocacy space. Sorry, I want to ask if my video can be, okay, thank you. So that being said, today's theme, access to new therapies, hope or hype, could not be more timely, more relevant, or more powerful. We stand at the crossroads of groundbreaking innovation and deep inequality. Bone marrow transplants, gene therapy, and novel drugs offer unprecedented hope. But for many in low resource settings, these remain distant dreams. This is why gatherings like today are critical. They bring together voices that matter, researchers, clinicians, advocates, and more importantly, patients and caregivers, to ask the hard questions, to demand better, and to chart new, bold paths forward. As chairperson, I'm proud to represent the Coalition of Sickle Cell NGOs of Nigeria, a unifying body for grassroots and national organizations working together to advance awareness, improve care, support affected individuals, influence policy, and ensure that no family faces this condition alone. Our mission is to foster a Nigeria where sickle cell is not a death sentence, but a manageable condition, supported by systems, empowered by education, and driven by equity. Our collective vision remains clear. A Nigeria where no patient, no warrior is left behind because of where they live or how much they earn. We believe access to life-saving therapies should not be a privilege for a few, but a right for all. Let us continue to amplify our voices and strengthen our partnerships and demand equity, not as a favor, but as a necessity. To the incredible panel lined up today, thank you for bringing your expertise and energy. To Sickle Cell Foundation, thank you for bringing bone marrow transplant into Nigeria. To every participant tuned in, your presence matters, your voice counts. Together, we are shifting the narrative from pain to possibility, from hope to action. Thank you once again, Sickle Cell Foundation, for this outstanding initiative. May today's dialogue spark real solutions and lasting change. Happy World Sickle Cell Day to every one of us. Let's keep pushing the boundaries for warriors and for survivors and for generations to come. Thank you so much. My name remains Timmy Edwin. I'm the chairperson of the Coalition of Sickle Cell NGOs.
Thank you, Timmy. Timmy Pro. Your name remains Timmy Pro. That's what we want to hear. But really, thank you for that message. It's important that people know, the world knows that there's a coalition like this. That is like that, because we often hear in this space, we're asking, why don't you come together? We have come together under this umbrella of the Coalition of Sickle Cell NGOs, and we will have to make it work. And there's a voice of those who know where the shoe pinches. You know where the shrinkage is, and which we are really advocating and pressing that whenever there are policies being developed, let us be part of it from the beginning. So we know best how these policies will affect us. So what's that thing I say in Latin? Nihil de nobis sine nobis. Nothing about us without us. It is coalition of sickle NGOs that moves that forward. Thank you so much. I will call on NCD Alliance, Non-Communicable Disease Alliance. I'm not sure if Professor Dr. Akinroye said, Dr. Kingsley Akinroye, the Vice Chair of NCD Alliance, or if it's their representative.
Yes, I'm on the line.
Hey, Professor KK Akinroye. We're delighted to have you, Professor, and Dr. KK Akinroye. I keep calling you Professor. Yes, I think you're both. Dr. KK Akinroye is the cardiovascular health physician, and he's also the executive director of Nigeria Heart Foundation. He's wearing many caps, many caps, and of course the vice chair of Non-Communicable Disease Alliance Nigeria. And you have another title in the global body of Heart Foundation and also the NCD Alliance Global. Dr. Akinroye, please, a goodwill message. Thank you.
Thank you very much, Annette. On behalf of NCD Alliance Nigeria, I bring you good tidings, and let me also pay my greetings on the line on the existing protocol. Sickle Cell Foundation Nigeria is a founding member of NCD Alliance Nigeria, and we are very proud of the trend and the fulfillment of objectives, which is still growing. Nigeria bears the highest burden of sickle cell, with more than 2 to 3% of the 200 million population suffering from the disease, including about 150,000 newborns that are affected yearly, and 50 million people carrying the sickle cell trait. Again, we note that the life expectancy of those who survive their fifth and birthday is about 21 years in Nigeria, lower than the life expectancy of sickle cell disease in high-income nations, which is average about 54 years. The high prevalence of sickle cell in Nigeria, with high mortality and morbidity, is a heavy burden to our growing burden of non-communicable disease, which we are still tackling. We have recognized that the sickle cell disease is a chronic disease. Hence, it belongs to the Non-Communicable Disease Alliance Nigeria, part of our very proud continental body, the African Alliance, and the global body of NCD, Non-Communicable Disease Alliance. NCD Alliance is committed to promoting the awareness, support for advocacy, training, and research in Nigeria and beyond. And we are also very interested in building support for the health systems from the primary to the secondary and the tertiary. Sickle Cell Foundation Nigeria, like I mentioned, is a proud member of NCD Alliance Nigeria, and we are committed to the efforts of the foundation in fulfilling its objectives. To this respect in Nigeria, we are hopeful that the Basic Healthcare Professor Fund will bring in sickle cell disease into the non-communicable diseases that are recognized. Now, at the moment, we know we recognize hypertension and diabetes, and in the NCD Alliance, we are still pressing that sickle cell disease be admitted or be recognized to be able to benefit from the Basic Healthcare Provision Fund, which covers at the primary care levels. What has been the achievement of the Sickle Cell Foundation? You will remember that in 2021, the Sickle Cell Bill was passed by the National Assembly, and this is still awaiting broad implementation countrywide. These are the immediate areas that need refocusing for large-scale implementation of stem cell transplantation and gene therapy, which we are warming up to today, and with more other innovations. On behalf of the NCD Alliance Nigeria, I want to congratulate the Sickle Cell Foundation of Nigeria and the panel discussants that are here today, fellow colleagues in the landmark of the civil society organizations, our researchers, our scientists. Best wishes on this landmark meeting. Thank you.
Thank you very much. Thank you very much, Dr. Kingsley Akinroye. we're really grateful that you graced this occasion. Thank you so much. I have a couple of goodwill addresses left. I'm not sure if the WHO representative is here. The WR in Nigeria, or is represented by someone else. The entire UN system is because remember that this is really is a United Nations event. The World Sickle Cell Day, June 19th every year, celebrated in accordance with what was established by the United Nations. So, as I often tell them, the UN system, this is your day. So, is anybody here from the UN system, the WHO, the unique United Nations Information Service? They're now in Abuja. Anyone here?
Yes, Dr. Akinshete.
Thank you. Who's here?
My name is Mary Dewan.
Mary, you see?
Yes, yes.
Okay, good to have you, Mary. Thank you so
Yes.
much, Mary. Well, please, can you introduce yourself? I know you're representing the WR. Thank you, Mary.
Yes, thank you so much. My name is Mary Dewan. I work on non-communicable diseases and mental health at WHO.
The audio, please, Mary. You are
Okay.
very. Thank you.
Okay. Sorry, is it better now?
Yes, it's better.
Okay, thank you so much. So my name is Mary Dewan. I'm a technical officer working on non-communicable diseases at the WHO Nigeria Country Office. And I'll proceed to give you a goodwill message. So Your Excellency, Dame Edith Okowa, immediate past First Lady of Delta State and the founder of 05 Initiative, distinguished guests, renowned professors and experts, warriors and champions and their caregivers, NGOs, CSOs, associations, the media, ladies and gentlemen. I will be giving this goodwill message on behalf of the WHO officer in charge, Dr. Alexander Chimbaru, who is unavoidably absent due to exigencies of work. It's my utmost pleasure to be invited as a special guest to the virtual panel discussion marking this year's World Sickle Cell Day. I must begin by commending the board and management of the Sickle Cell Foundation, Nigeria, for the work you do to raise awareness on sickle cell disorders and providing comprehensive services to individuals living with this disorder. I congratulate you and for organizing this virtual panel discussion with the theme, Access to New Therapies, Hope for High, as this has brought us all to deliberate on the issues of sickle cell disorders. I must also acknowledge all stakeholders here today, including our warriors and champions, for your individual and collective efforts towards preventing and controlling the sickle cell disorder in Nigeria. So every year, the World Sickle Cell Day is commemorated on the 19th of June, and it's aimed at increasing awareness on sickle cell disorder and the need for urgent action. The day also serves to draw our attention to the challenges faced by individuals and families affected by this disorder. This year, the global theme is global action, local impact, empowering communities for effective self-advocacy. And it's aimed at uniting the world to embrace community-driven initiatives to ensure better care and support for those affected with this disorder. At this juncture, it will be useful to remind us all, even though the various speakers have mentioned, that among more than 120 million people affected globally by this disorder, close to 70% hail from Africa or sub-Saharan Africa. And on average, 1,000 children are born every day with this disorder, making it the most prevalent genetically acquired disease in the African region. Unfortunately, more than half of these children die before they mark their 50th birthday. So as WHO, a strategy for sickle cell disease for the African region was developed and adopted by member states during the 66th Regional Committee for Africa, where all the ministers of health meet to deliberate on key issues on health. And the strategy provides a set of public health interventions to reduce the burden of the disease through improved awareness, disease prevention, and early detection. In 2022, a campaign was launched by the African health ministers to enhance advocacy and shore up political will and engagement, as well as dedicate financial resources for sickle cell disease prevention and control across the region. Additionally, we have the package of essential non-communicable diseases interventions, which was adopted during the which was adopted during the 72nd session of the Regional Committee. And this also is aimed at addressing severe non-communicable diseases, including sickle cell disease, through an integrated approach. Most recently, the WHO sickle package of interventions for sickle cell disorder management was developed for use by member states. As I conclude, I would like to enjoin us all to continue collaborating and working together towards promoting equitable access to health services to those affected by the disorder. As the WHO, we remain committed to supporting member states and partners in their effort towards the prevention and management of this disorder. Thank you so much for your attention and wishing us all successful deliberations. Thank you, and over to you, Dr. Appreciate.
Thank you very much, Dr. Mary Derwan. Thank you. We're grateful that the WR asked that you represent him, and thank you for doing that. WHO is the agency in charge of health in the UN system. Thank you. We have Ministry of Health, Lagos State. We are in Lagos. Sickle Cell Foundation Nigeria, we operate out of Lagos. So there's no way we will not have Lagos State say a few words. So Dr. Abosede Wellington is the coordinator for non-communicable diseases and, well, of which sickle cell is one, the Lagos State Ministry of Health. Dr. Wellington is the Deputy Director. Dr. Wellington, please, for your goodwill address. I saw her. Unmute yourself if you're not.
Okay, yeah. Good afternoon.
Good
I hope you can hear me.
Yes.
Good afternoon, everybody.
We can.
Okay. Thank you for the opportunity. Good to be on the call. My name is Dr. Abosede Wellington. I'm the NCD coordinator, which also includes sickle cell disorder control for the Lagos State Ministry of Health, like Dr. Makishete rightly said earlier on. I bring greetings from the great people of Lagos State. I want to also stand on the existing protocol, but I would just briefly like to say salute Dame Edwitam Okuwa, Professor Makani, Professor Bazwaye, of course, my Professor Dekile, Professor Kiola, and all the other experts on the call. I'd also like to recognize the sickle cell warriors on the call and other caregivers, the gentlemen and gentleladies of the press, and other advocates and stakeholders, and also everyone else on the call. Like I said earlier on, I bring greetings from the great people of Lagos State, but I'd like to say that my executive governor, Mr. Babajide Olusola Sanwo-Olu, says hi. So also does my Professor Akiabayomi, my Honorable Commissioner for Health. Likewise, Dr. Olukemi Ogniemi, a special advisor to the Governor on Health, and my Permanent Secretary Health, Dr. Olusegun Ogbuyi. I won't leave out my Director, Disease Control, Dr. Victoria Egbedobi. I want to thank Sickle Cell Foundation Nigeria for the opportunity to be on this call. We want to say thank you again for, we had this last year. We want to say kudos to Sickle Cell Foundation for repeating this again this year. This is wonderful. Lagos State, as we all know, is a pioneer state to commence the free targeted routine newborn screening, which we offer in 65 stated facilities. And we're planning to actually scale up to 75 facilities before the end of this month. We also provide routine and periodic community and school know your genotype screening outreaches, which is just, just to encourage people to know what their genotype is so they can make informed health decisions. I would also like to say well done to Sickle Cell Foundation for the bone marrow transplant center that we have in Louth. It has been a dream in the making for a while, and the Lagos State government has been in partnership with the foundation in making this a reality. And we're also very ready and very continue to make this dream, not just it is a reality already, but also to improve on this reality. Thank you very much, everybody. And I chose all a very wonderful and deliberate discussion. Thank you very much.
Thank you very much. Thank you, Dr. Abosede Wellington. Thank you very much. And might I add, because I use any opportunity I see to put it out there, that Lagos State is part of our bone marrow transplant program. The first donation we got to begin to put that center together came from Lagos State government. I think it is a applause for that. Thank you, Lagos State.
Thank you.
Though that partnerships can, transcend levels of government. So level, national government, subnational, and private sector. So public-private partnerships, they really work. Thank you very much. We must acknowledge that. Dr. Alayo Chukwekon, Director in the Public Health Department of the Federal Ministry of Health. That's the ministry at the national level. Dr. Wellington is in the ministry at the subnational level, Lagos State, where we are domiciled. Dr. Alayo Chukwekon is the director and is in charge of sickle cell disorders and I think other inherited blood disorders in the Federal Ministry of Health. Dr. Alayo, are you with us? Dr. Alayo Chukwekon, are you muted? Dr. Alayo is very busy. He may not be on this call. Dr. Alayo Chukwekon, are you here? Admin or hosts, can you see Alayo?
I'm not sure he's on the call. I can't find him.
Okay, that's all right. So we'll move straight away to the substance of today.
It's not on the call.
Waiting with bated breath. Did I hear that Alayo is here? No. So I think
he's not on the call.
Okay, good. Caleb, should I move on?
Yes, ma, please move on.
Okay, good. So like I said, we've all been waiting with bated breath for this moment. This is that moment. And I'm going to introduce our keynote speaker. And I think that, quite frankly, introducing Professor Julie McCartney will take, really, if you want it to be done properly, will take like 3 hours. But this is a very, very compressed, extremely concise, bio of who she is. But where she's bringing, we're very grateful to Dr. McCartney, Professor McCartney, for bringing her expertise and knowledge and her international and global exposure and work in this space to the table here, so that we all sit around this table and discuss. Professor Julie McCartney is a Tanzanian physician scientist. She's celebrated for transforming sickle cell. So she graduated from as a medical doctor from Muhimbili University of Health and Allied Sciences, MUHAS, in 1994. A Commonwealth scholarship led her to the UK in 1997 for postgraduate training in internal medicine at Hammersmith Hospital, where she earned her FRCP. She later completed a PhD under a Wellcome Trust fellowship, focusing on the clinical epidemiology of sickle cell disorder, with supervision from the University of Oxford and King's College London. Please, where else can you gather all the knowledge in the world, if not all of this in one person? In 2003, Dr. McCartney established the Sickle Cell Program at Muhimbili University of Health and Allied Sciences, enrolling over 2,000 patients into prospective studies. This cohort has now grown more than 5,000. I can hear feedback. Please do something about that. Making it one of the world's largest single-center sickle cell research efforts. Her work has brought to light the roles of malaria, bacterial infections, stroke, anemia, fetal hemoglobin, and hydroxyurea treatment in disease progression and mortality. Professor McCartney has been instrumental in building collaborative networks aimed at strengthening sickle cell disorder research and healthcare delivery. She co-founded the Sickle Cell Foundation of Tanzania and helped establish national and regional initiatives such as REDAC, SPARKLE, Sickle in Africa, Sickle Gen Africa, and H3A BioNet. Together, these platforms integrate research, genomic insights, policy training, and public health implementation across East, Central, and West Africa. I think she has insisted that I emphasize, I should note that this has been a collaborative effort. She's part of many other people, the persons who have worked together to make this possible. Her contributions have been recognized by major honors: the Royal Society Africa Award in 2011, an Archbishop Tutu Leadership Fellowship in 2009, inclusion in BBC's 100 Women in 2019, and the French Ordre National du Mérite for her scientific achievements in 2022. Today, as a professor at MUHAS, provost, visiting professor at Imperial College London, and science advisor at the Tanzania High Commission in the UK. She continues to work on efforts that harness genomics, clinical epidemiology, and implementation science to address sickle cell disorder. Her vision uses sickle cell disease as a model to build sustainable African-led scientific solutions that reduce health disparities and empower local communities. Professor Makani stands as a role model for African scientists, illustrating how world-class context-relevant research in Africa can reshape global health. So I give you Professor Julie Makani. Professor Makani, please.
Hello, everyone. Thank you very much, the Sickle Cell Foundation of Nigeria, for inviting me to give this talk. I'm going to move the slide back. How do I do that?
Professor Makani, I've been itching to ask a question, and I'll just ask it here, please. Everyone forgive me. Is it Tanzania or Tanzania?
Tanzania.
Tanzania.
Yes.
I think anglicizing when we say Tanzania. Sorry about that. Please carry on.
No worries, no worries, Tanzania. So thank you very much to the Sickle Cell Foundation for inviting me to speak on behalf of many people who've been working for many years on sickle cell disease. I stand on existing protocol, and thank you everyone for attending this and making the time to join us as we celebrate World Sickle Cell Day for 2025. So I will speak about advanced therapy for sickle cell disease in Africa, really highlighting blood transfusion, bone marrow transplant, and the pathway to gene and cell therapy that we have taken in Tanzania and other colleagues have taken in other countries within Africa. I'll switch my, well, maybe I'll leave it on. But knowledge, sorry?
Yes, you want them to change the slide whenever you're ready.
Yeah, no, I'm ready. I'm managing them from my side, so this is okay, yeah. So I really just want to acknowledge the many countries and individuals and institutions that are part of the Sickle in Africa Consortium. I really like to acknowledge Professor Obiageli Nodu, who is the lead for Nigeria, covering 25 sites in Nigeria as part of the Sickle in Africa Consortium and the other countries that you see over there. Ghana, Nigeria, Mali, Tanzania, Uganda, Zambia, Zimbabwe, and Clinical Coordinating Center in Tanzania and the Data Coordinating Center in South Africa. We also would like to acknowledge individuals, institutions, and partners that are part of the work that we've been doing over the past 20 years. But most importantly, it's acknowledging the patients and the people who are living with sickle cell disease, caring for people with sickle cell disease, living with people with sickle cell disease. Really, this is acknowledging and appreciating your willingness to let us work together. So I just want to give a little bit of context about sickle cell disease, is that from a perspective of genomics to health, or gene therapy, which is one of the things that we'll be talking about today, sickle cell disease is considered to be a model disease for genomics to health for three reasons. The first is that it has high heritability, meaning that it's an inherited disease. Secondly, is that there is an unmet medical need. And the third is that there are limited interventions. And I think all of us can agree that sickle cell disease demonstrates an unmet medical need and there are limited interventions. So sickle cell is considered to be the first genetic disease. It was first described by Linus Pauling and his colleagues in 1949, describing the genetic mutation that led to the abnormality in the hemoglobin, leading to sickling of cells. And so this sickle cell disease is the first genetic disease. Secondly, when we talk about it being an unmet medical need, is that it's very common.
over 500,000 children are estimated to be born every year with sickle cell disease, and the majority of these individuals are in Africa, and the majority of these individuals are born in Nigeria. From Tanzania, which is the country that I come from, we're the third country in Africa with the highest number of children born with sickle cell disease and a high level of complications and risk of death. And so for us as a country, Tanzania has prioritized sickle cell disease and has included it as a priority condition in the non-communicable disease strategy with the aim of addressing it. In addition to it being common, it causes severe disease and has a high risk of mortality. If you're born with sickle cell disease in many places in Africa and you do not know that you have sickle cell disease, you have 80 to 90% chance of mortality by the age of 18. However, if you know that you have sickle cell disease and look after yourself, we see that mortality has reduced, has gone down, and we now are seeing more and more children living to the age of 18, more and more adults surviving from 18 and living productive lives. Very similar to the situation in Jamaica, the US, and the UK, where childhood survival was high. And we're really pleased that efforts that have been made by many people has been able to improve childhood survival. However, the situation is not solved. We know that we can make a difference in children under the age of 5. And if you look at this graph, I hope you'll be able to see my point. You'll be able to see that in the first 3 years of life, mortality can be reduced by 70%. Now, if you look when older children and adolescents and young adults, there's very little change in mortality. And as we all know, living with people who have sickle cell disease, we know that this life is associated with a lot of complications, particularly pain, leg ulcers, infections, a risk of stroke. And so the concern, and this is the situation in the US, so the trends in mortality, sickle cell disease in the US, a high income country. And so the discussion has been, how can we improve the situation in the first 5 years of life by newborn screening and comprehensive care? But how can we provide bone marrow transplant, which is a curative therapy, and gene therapy, which is, I'll talk about a bit more, is also a curative therapy for individuals with sickle cell disease. And so the strategy really has been, how do we do two things at the same time? How do we improve health, and how do we find a cure that can be available, accessible to the millions of people who are affected by sickle cell in the world? Now, when we talk about sickle cell as a public health disorder, we talk about it in the sense of how do we address populations rather than individuals? And when you look at the current treatments that are available for sickle cell disease, most of us in Nigeria, Tanzania, Africa, we know now more and more about hydroxyurea. So that's an option that is available. Bone marrow transplant is curative. We know that it cures, but there are limitations to it because you need a matched donor from to give you the stem cells for you to cure the disease. And there are other limitations to bone marrow transplant, but this is a cure. And this is something that I'm really, really excited to share, is available in Nigeria, is available in Tanzania, is available in South Africa, and more countries are looking to see how they can make bone marrow transplant available in their countries. For those who do not have facilities, we have seen an increase in the number of people with sickle cell disease going to India particularly and getting bone marrow transplant and returning to our countries. So that option as a treatment is available. Then the most exciting thing, or the exciting new thing, is gene therapy. And there are two types of gene therapy. There's ex vivo gene therapy, which is a type of bone marrow transplant stem cells, blood stem cells are taken from the body, modified and given back like a transfusion. And in vivo gene therapy, which is what we're all hoping that will be developed in the next 5 to 10 years, where a simple injection will result in a patient receiving the gene therapy and being cured of the disease. Now, one of the things that we have been often asked is, can we have both? Can we have both public health interventions and curative health interventions? And why are they presented like two separate things, that you can only have one and not the other, or you should have one first and then work on the other? And so the discussion has always been, or has been increasingly, with public health agencies such as the WHO, with ministries of health, is, should we prioritize public health interventions, newborn screening, managing infections, and providing patients with comprehensive care and access to hydroxyurea? Or should we think about curative health? And so the question is public health or curative health? But we would like to suggest that rather than looking at it either as an either or, why don't we try and work on public health and curative therapy? And there's no reason why different people in different countries in different ways address both public health interventions and curative therapy. And this is a set of slides that shows you what we have done in Tanzania with regard to improving diagnosis as part of newborn screening, providing comprehensive care at primary, secondary, and tertiary healthcare facilities, having a system of referring patients so that they can get specialized care, whether it is transcranial Doppler, MRI, or CT for patients who are at risk of stroke, management of avascular necrosis or complications of the bones, as well as leg ulcers, making sure that patients have access to disease-modifying medicines. And our focus as countries in Africa has been access to hydroxyurea. We need to improve blood transfusion and access to blood transfusion. And I'm really pleased that many patient groups, patient-led groups, have identified and have been focusing on how we can improve blood transfusion and increase the number of blood donors so that we can have better transfusion access for our patients, and then blood and bone marrow transplant. And one of the questions that we often get asked is, why do you work in sickle cell disease? There's very little research that's going on. There's very little cure. Isn't it discouraging to work on a disease that is not really particularly important at many levels? And our answer is yes. It is important for us to work on sickle cell disease. Very simple, because patients, people with sickle cell disease need the disease, need help, need healthcare interventions, need curative interventions. And as a physician scientist, so I'm both a doctor and a scientist, it's really prioritizing or saying that, or quoting Francois Benoit Barré-Sinoussi, who received the Nobel Prize for describing the HIV virus, is that we're not conducting science for science. We want to conduct science for the benefit of humanity. And if, as a scientist, you're working on a human disease, you must have a relationship with people living with the disease. And so it's really encouraging to see the number of patients, individuals, warriors, advocates who are on this call today. So why are we discussing curative therapy for sickle cell disease? The focus of my talk today and the theme for this talk, for this webinar, is really new therapies or curative therapies for sickle cell disease. And why are we discussing that? We're discussing it because in 2017, so close to 8 years ago, Jean-Antoine Ribéry and Marina Cavazzana in Paris published this paper where they said that they had successfully cured a patient with sickle cell disease using gene therapy. We have a very active patient community in Tanzania, and these are photographs of Ramadhani and Nasra. Ramadhani is a boy and Nasra is a girl. They're siblings. And this is a photograph from Shani, their mother, and we have approval to share this. They simply said, how can we get the cure? We know that some patients in France are being cured from using gene therapy. Can we get a transplant? Can we get access to gene therapy? So as a physician, as a scientist, we weren't able to say, and again, somebody said this earlier, we weren't able to say, well, you cannot get a bone marrow transplant or gene therapy because you're from Tanzania and we do not have that. We worked with the mother and she said, we would like to get access to the cure. We were also very fortunate that the government of Tanzania was also extremely supportive. They received a lot of queries saying, how can we support the patients with sickle cell disease from Tanzania? How can they get the cure? It's not practical for us as a government or for the government of Tanzania or any country to send patients outside of the country for treatment because it's just not practical at many levels. So this was a paper that was published in 2021 looking and describing sickle cell centers, treatment centers that are available in Tanzania. And this is not comprehensive because we know that almost all the 54 countries in Africa have treatment centers for sickle cell disease. I want to point your attention to the map on the right-hand side. Is you will see that there are 3 countries, South Africa, Nigeria, Tanzania. These are countries that we're working together, countries that have centers for bone marrow transplant. We also saw in 2019 in Ethiopia, NIH and the Gates Foundation committed $400 million for research into gene therapies for sickle cell and HIV because there's a lot of convergence, a lot of overlap from a research perspective between HIV and sickle cell disease from the perspective of gene therapy. And there's various types of gene therapy. There's gene silencing, gene addition, gene correction. And so the fundamental principle of it is that your stem cells, your blood stem cells are taken from your body, modified in a outside of your body, and then given back to you as part or similar to what we call an autologous transplant. The specific thing that is happening, this is called ex vivo gene therapy. It is a type of bone marrow transplant, and it requires what we call conditioning or treating the bone marrow with myelosuppressive drugs. So these are drugs or medicines that suppress the bone marrow so that it can make space for their modified blood stem cells. What happened in 2023 here in the UK was regulatory authorities approved the use of gene therapy for sickle cell disease in the UK. And then a month later, the US also approved gene therapy. So now these are therapies that are approved and have passed the regulatory authorities to be used for treatment of sickle cell disease in the UK and in the US. There have been trials that are ongoing on gene therapy to improve the types of gene therapy and to find out what works best for which patient, and the approvals, as I've mentioned, and really incredible to be around at this time is really to see the NHS, this is the National Health Service in the UK, actually approved in December of last year, December of 2024, they approved 50 patients to be treated on the NHS with gene therapy. And this is probably the first or the second country in the world to provide a genetic treatment for sickle cell disease using the public health system or in the public health system. So when we were looking at this as a country, as a network, as researchers, we were saying, well, we want to do gene therapy trials in Africa. We have the networks, we have the people, we have the expertise. There's been an investment of $200 million for research. how many gene therapy trials in sickle cell disease have happened? And the answer is no. There have been no gene therapy trials for sickle cell disease in Africa. And there have been many, many reasons that we have been told that you cannot do gene therapy trials. Many, many reasons. I won't go through them, because what we did, as we have done with other situations where we face similar reservations and pushback, we just said this is an issue of ethics, this is an issue of equity, and we do have the experience and the expertise to conduct gene therapy trial for sickle cell disease. So all the people, all the concerns that were raised, we just said we will slowly and systematically address them so that we can ethically and in an equitable manner provide gene therapy and curative therapy for patients with sickle cell disease in Africa. And from a research perspective, the question is it really important to conduct gene therapy trials in Africa? Why don't we do the trials in the UK, in the US, in France, outside of Africa? And then once we know what works, we just come and apply them. And the answer is, this is not possible. We need to conduct the gene therapy trials in Africa because we know that people in Nigeria, within Nigeria, are very different. People in Nigeria and in Tanzania are different. So if one intervention, one therapy works in one place or in one population, it doesn't necessarily mean it will work in another population. We also need to conduct research to understand access, affordability, and to really evaluate whether the gene therapy interventions or medicines will be safe, efficacious, and will have no toxicity in our setting. And so what are the things that we have been doing? And when I say we, I'm using the royal we, working with people, with populations in partnerships and as part of policy to find a cure for sickle cell disease, really focusing on listening to patients and listening and being sensitive to what patients want. And we do know, not every patient, but we do know that there are people who want a cure for sickle cell disease. You look at the number of people with sickle cell disease in the world today, we have close to 8 million people. 6 of them are in Africa. And so this is really a problem for us as people in Africa, that the majority of people with sickle cell disease, at least 6 million, let's assume 1% of them need access to gene therapy. How are they going to get access to that? So our approach has really been the approach that we've taken to look at sickle cell disease. And this is an approach that we started 20 years ago when we set up the sickle cell program in Tanzania, where we had an integrated approach that coordinated activities, worked very closely with the patient community and the public, really highlighting and improving healthcare, advocacy, research, and training to address sickle cell disease. And over the past 22 years now, we've been very, very fortunate. From when we started the sickle cell program at Muhimbili National Hospital, now, where, as you've heard, we are now working with WHO Afro to see what are the things that need to be put in place to make sure that public health policies are in place to provide screening, newborn screening, diagnosis, as well as hydroxyurea access for the 8 million or 6 million people with sickle cell disease in Africa. We've worked with policymakers to include sickle cell disease, the NCD policy, and this is when it was being launched in 2016. So this was the Minister of Health and the Prime Minister. Sickle Tanzania, led by colleague Professor Emmanuel Balande, have spread the number of sickle cell services and clinics, so patients don't have to come to 1 or 2 facilities. And then we've been working at regional level in East and Central Africa, as well as at Africa level, with at least countries that are part of the Sickle in Africa Consortium. Specifically with the Sickle in Africa Consortium, initially, this is a network that is funded by the NIH, the National Institute of Health in the US, And we said that three countries, Ghana, Nigeria, and Tanzania, we are able to enroll at least 13,000 patients with sickle cell disease across the age group. And we were able to do that in the first phase. In the next phase, additional countries became part of the network. These were Mali, Uganda, Zambia, and Zimbabwe. And to date, over 40,000 patients have been registered. Now, this is one of the largest networks of patients with sickle cell disease in a registry. But just a bit of context, 40,000 patients, and we have a global population of 8 million and a population in Africa of 5 million. We're only reaching the tip of the iceberg with regards to the number of patients. We need to do more, and we need to do more now. Going back to this, with treatment centers and centers of excellence, I'll really give examples of what is actually happening with regards to gene and cell therapy in Africa. We talk about it as if it's in something that's going to happen in the future or in a few places, but gene and cell therapy is actually happening in Africa. The first example is in your country, in Nigeria. We in Tanzania and other countries were really inspired by Professor Noza Bazwaye, who started doing bone marrow transplant over 10 years ago in Benin State. We were in admiration and motivated, saying if he can do it, then surely we can do this as well in Tanzania. You've heard from the Sickle Cell Foundation of Nigeria and the work that is in partnership between the foundation and the Lagos University Teaching Hospital, really admiring the fact that you have started now doing bone marrow transplants in Lagos. And then really, I was in Nigeria last week, and I was really, really motivated to see the opening of the African Medical Center of Excellence, because this is where you will be able, in Abuja, to do bone marrow transplant gene therapy, not just for Nigeria, but for people from Africa. So really a warm congratulations to Nigeria. This photograph here again was from last week during the Global Congress for Sickle Cell Disease that happened in Nigeria. Sanodu, who is the lead and was the chair of the conference. But I want to point your attention to this gentleman here. This is Jimmy Olagere. He's of Nigerian origin, and he has sickle cell disease, had sickle cell disease. He was born and moved to Nigeria for treatment, and he is one of the first 5 patients who received gene therapy. His sickle cell disease has been cured. So successfully, he was able to climb Mount Kilimanjaro, the highest mountain in Africa, in Tanzania last year. And last week, he was in Nigeria to talk about his experience with gene therapy and how it cured him and has given him a new form of life free of sickle cell disease. Professor Noza Bazwaye, who will speak, and this is a colleague, Professor Jean Ade. Professor Jennifer Ade is based now is based at University of Massachusetts. She and Dr. Sisi Kicho from Uganda, when they saw that $200 million for sickle cell and HIV, and none of that funding came to institutions in Africa, formed a global gene therapy initiative and said, we are going to address all the reasons that are being put forward, and we will start doing gene and cell therapy for sickle cell and HIV in Africa. The next example is in Tanzania. Tanzania established and has now 2 bone marrow transplant units, one in Dar es Salaam in Muhimbili National Hospital, led by Dr. Rezaula, and a second one in Dodoma, which is the capital city for Tanzania, at Benjamin Mkapa Hospital, led by Dr. Stella Malangai. If you want to do bone marrow transplants, you could say that your name is Dr. Stella, and you should be able to do them. This is really, and for us as a country, we're really proud of Benjamin Mkapa Hospital and MNH, because they just went out and did the transplants. And we were very fortunate because the president of Tanzania, President Samia, actually provided funding for the bone marrow transplant center in Dodoma and in Dar es Salaam. And this is a photograph of the president when she visited the bone marrow transplant unit. All these are four patients with sickle cell disease, a donor to her brother, and they are patients with sickle cell disease who have been cured with bone marrow transplant. And this is a partnership between Tanzania and Italy in successfully establishing bone marrow transplant for sickle cell in Tanzania. And last, I think 2 months ago, the East African community has recognized this bone marrow transplant center as a regional center of excellence for bone marrow transplant for the East Africa region. And then finally, for gene and cell therapy in South Africa, Professor Johnny Mahlangu, who was in Nigeria last week as part of the Global Fix, he just started doing gene therapy. His area of expertise and experience is hemophilia, which is a type of blood disorder. But he very quietly, very efficiently just started preparing and has started doing gene therapy for hemophilia, and has published a paper 2 years ago saying that, yes, we can. As African scientists, as African healthcare providers, we can do this in Africa. So what can we do to bring curative therapies for sickle cell disease? It really requires us to partner. And I'm really glad that the different speakers who are giving goodwill messages really spoke about partnerships. We need to partner with the private sector. The Africa Medical Center of Excellence is a private institution. We need to partner with philanthropy. We need to partner with government. We need to partner with industry in order to make this happen. We need to work at different levels with different people. Not one person can do this. So it doesn't matter what you're interested in, whether you're interested in social science, patient advocacy, basic science, clinical science. From a research perspective, we need all hands on deck. We need everybody working together in a coordinated, collaborative manner to make this possible. And these are examples in Tanzania. And then we need to work with policymakers, with financing agencies. The transplants, the gene therapy are expensive. So it's not fair that only a limited number of people will be able to access them. So how do we make gene therapy? How do we make bone marrow transplant accessible? This is something that we can't answer as healthcare providers. We can't answer as health scientists, but we have really clever people who work in financing agencies who will be able to tell you this is the model that needs to be put in place in order for our patients to access this. And then finally, it's really partnership. And this is an example of what colleagues in the UK under the leadership of people like Dr. Stephen Okoli, Dr. Norris, and others really working at Imperial and in the UK with colleagues, looking to see how they can work with governments, with national agencies, financing agencies, and industry in order to make bone marrow transplant and gene therapy accessible. Because when I mentioned that the NHS is providing gene therapy for sickle cell disease, it can only afford to pay for 50 individuals a year. England has a population of at least 10,000 people with sickle cell disease. So they also, as a high-income country, they also need to look at the access issue. So it's not a problem that we are facing in Tanzania or in Nigeria. Even the UK and the US are looking to see how do we make therapies accessible to individuals that are affected by sickle cell disease. And then finally, this is a piece of work that was published, 2 papers, one by Kevin Duxon and the other one by Dr. Daima Bukini, really looking at it and looking at what people are doing so that we can learn from each other. So in Tanzania, sickle cell disease, in South Africa, hemophilia, Uganda, HIV, Brazil, hemophilia, India, leukemia and CAR T therapy, and Thailand, transplant not transplant, gene therapy for thalassemia. And so finally, the reason why we're really passionate about this, and again, thanks to the Sickle Cell Foundation of Nigeria for inviting us, is that when we think about gene therapy and bone marrow transplants and curative therapy, it is not hype. This provides hope for patients. And we need to work in a manner that is promoting partnerships, learning from each other, because we need to make sure that we provide access to these treatments in a timely manner. With every day that we're talking about doing this, that we're not working together, that we are saying, let's do one thing and not the other, we know that patients are suffering and we know that patients are dying. So we have an obligation to try and work and do this now, not tomorrow. Thank you very much for listening, and thank you very much again to the organizers for letting me share the experience, and really credit to all the people who have been doing this work for a very long time. Thank you.
Wow, brilliant. And I wish we could really applaud together. Brilliant, brilliant, brilliant. Thank you so much, Professor Julie Makani. Yes, it is not hype, she says. It is not hype. It brings us hope, but it does take what? Partnerships. I think I see you putting that front and center. Partnerships. Thank you. But we still have to think, for us, particularly us in Africa, sub-Saharan Africa, we need to think deeply about exit strategies from funding, from external funding, because we have suffered that over time. We should have learned by now. And I think with the political upheaval in America, where there are implications right now. So let's think about that during this discourse and beyond. And then talking about gene therapy, yes, we're ready for it in Africa. There's no saying that we're not. Let's even start with the trials. And you are correct. There are population differences genetically. So we need to have the trials for our own people. Okay, but again, the issue of accessibility is universal. It's everywhere, because after all, resources are not unlimited anywhere in the world. But I think for low-income countries, there are more layers to inaccessibility. Thank you so much, Professor Makani. Asante Sana. I think I said that well. I have East African connections. My name is actually Wanjiku. You ask, I'll tell you why later. How? Wanjiku. Shiko. Anyway, good. Now we go. Caleb, am I right to go on straight to the moderator? Introduce her and she can take over. I think I'm going to do just that. Caleb, are you there? I want to be sure I'm doing the right thing. Mm-hmm.
Yes, ma, kindly proceed.
Okay, excellent. So I'll do that now. I'm going to introduce our moderator. First, let me just acknowledge our moderator. She's waking up at 4 in the morning to be here with us in faraway Dallas. Houston. Yeah, in Houston. I am really grateful to you and Dr. Titilope Fashikbe, MD, PhD. I know you're MD, PhD, but I think we'll discuss a side gig for you, because you do this thing, you can do it in your sleep. Something you must consider. Dr. Fashikbe is co-director of the Sickle Cell and Thalassemia Program at Texas Children's Hospital, and assistant professor of pediatrics in hematology oncology at Baylor College of Medicine. She's passionate about public health strategies that target the psychosocial barriers and health complications of individuals with sickle cell disease. She's actively involved in various sickle cell-focused community and policy efforts that are aimed at understanding and addressing these challenges. Dr. Fashikbe has been repeatedly appointed to sickle cell-related advisory committees of the Texas Department of State Health Services, and currently she chairs the Sickle Cell Task Force. Her national leadership roles include Texas Lead, Heartland Southwest Sickle Cell Disease Network, Chair Sickle Cell Disorder Advisory Committee, National Heart, Lung and Blood Institute, Chair, Technical Expert, Panel for Sickle Cell Disorders in Quality Measures, American Society of Hematology, ASH, Chair, Sickle Cell Disease National Community Advisory Board, ASH Research Collaborative, and past Chair, Hemoglobinopathies Special Interest Group, American Society of Pediatric Hematology Oncology. Dr. Fachikwe has a unique perspective of relating to and understanding the need for education, community awareness, support, and medical care, as she's a pediatric hematologist, as well as an individual with sickle cell disorder. So she has the perspective all around. And like I said, Titi, we're going to discuss the side gig after this show. Thank you so much for agreeing to do this, to attempt to do this for us. You do it so well. And I really doff my hat for you. So over to you. You take, now is your show, take it up from here and introduce our panelists. I just suggest that you consider the panelists that we have here now and just introduce them alone for the purpose of saving time.
Yes.
Thank you. Over to you, Titi.
Thank you so much, Dr. Akinjete. I am honored to be invited back to serve as moderator for this wonderful event. And I was just inspired, like so many of you, listening to Dr. Makani. So thank you so much for this privilege. And I can continue expressing gratitude, but because of time, I want to move on to introducing our distinguished panelists. I will start with Dame Edith Okoa, who you heard from earlier today. Dame Edith Okoa is the former First Lady of Delta State. And as First Lady, she founded the O5 Initiative, which is a social outreach program and focusing on the sick, hungry, thirsty, clothing the needy, and housing the homeless, and also ministering to prisoners. She then also took her advocacy gifts and brought them to sickle cell disease. And while she was under the Delta State leadership, she established 23 sickle cell clinics. And these are not just basic clinics. She equipped them very well to do everything from newborn screening to transcranial Doppler. And so I just wanted to acknowledge the fact that she is a champion humanitarian, and we're grateful to have her here today. Our next panelist is Professor Adekunle Adekile, who you already heard from as well. Professor Adekile is a recently retired professor in the Department of Pediatrics in the Faculty of Medicine of Kuwait University. And his lifespan dedication to sickle cell disease is quite evident in his over 40-year career, starting from the days of learning under Dr. Roland Scott in Washington, D.C., all the way to establishing the first sickle cell clinic in Obafemi Awolowo University Teaching Hospital. And then from there, just his excellence and his dedication continued to mount. I want to say that he's the founding chairman of the Nigerian Sickle Cell Disease Network and the Sickle Cell Support Society of Nigeria. And he also currently is serving as editor-in-chief of the journal Hemoglobin, as well as his role being chairman of GANSID, the Global Action Network of Sickle Cell and Other Inherited Blood Disorders. Again, we are privileged to have him here today. And then I don't think Dr. Shopekan has arrived, so if he does, please let me know. I'll move on to Dr. Abosede Wellington. It was wonderful to hear her goodwill message. She's
just so you know.
Yes. You said that we have her? Yes.
She's here.
Yes, thank you. Yes, and so Dr. Wellington is an accomplished public health physician, and she has 2 decades of serving our community here in Lagos, and she's currently holding the position of Sickle Cell Disorder and Cancer Control Coordinator for the Lagos State Ministry of Health. What I love about her is that she has this steadfast belief in the power of collaborative efforts, and she feels that working together with other stakeholders will bring us closer to our goal, especially in the successful control of sickle cell disease in Nigeria. And then I don't believe we have Laycon yet, but we will be looking out. And then Professor Nora Akinola. Professor Nora Akeola is a distinguished hematologist, and she also has several decades of dedication and service to sickle cell disease. She is currently serving as a professor of hematology at Obafemi Awolowo University in Ile-Ife, and she's also an honorary consultant in their teaching hospital complex. One of the things that brings her to this impressive panel is that she has served in understanding the impact of newborn screening and clinical outcomes in sickle cell disease. And then beyond her academic career, she's also this prominent voice in public health advocacy, and she serves as the coordinator for the Southwest Zone of the Nigerian Sickle Cell Association. Our next panelist is Professor Olufunmilayo Olopade. She is a world-renowned Nigerian-born hematology oncologist. Many people may recognize her from her wonderful work in breast cancer, understanding breast cancer in the African populations. She's also the Walter L. Palmer Distinguished Service Professor of Medicine and Human Genetics at the University of Chicago, and she's the Associate Dean of Global Health, and she leads their Center for Clinical Cancer and Genetics. So how did a breast cancer physician come to a sickle cell panel? Well, she brought her talents to the world of sickle cell by becoming a strong partner with Sickle in Africa, where she co-chairs a Pan-African network dedicated to sickle cell disease. And she's mentored several of the physicians and clinicians and researchers under the Sickle in Africa network. And so we're excited that she's able to join us today. And then I also wanted to introduce, I believe, Dr. Karia. I don't think I see him. If the panelist, if the admin sees him.
Yeah, Dr. Gaurav. Very likely. I think I saw him earlier.
I thought I did, but we'll come back to him.
No, okay, you can go on.
All right. And then I did see Dr. Adeshaya Michael Akinshete earlier, but I don't know if I see him again. He was here earlier.
He's on the call.
Okay. So Dr. Akinshete is a consultant pediatric hematologist at the Lagos University Teaching Hospital, and he serves as the lead transplant physician for the Sickle Cell Foundation Nigeria and the Luth Bone Marrow Transplant Program. One of his important spaces is that he also teaches in the Department of Pediatrics. And he went to Birmingham Children's Hospital to get more training in bone marrow transplant, and he was able to bring this to Nigeria and is now impacting several children's lives. And so we're excited that he's able to join us. And then I think I did see Professor Nosakare Bazuaye present as well. Professor Bazuaye is the Deputy Vice Chancellor and the Chief Medical Director at Igbin Edion University Teaching Hospital. And as you heard from Dr. Makani's presentation, during his time in Benin, he orchestrated the first successful transplant for sickle cell disease in sub-Saharan Africa. And this was in 2011, so over 10 years ago now. And the important thing is that he went beyond just transplant. He also looked at the role of blood transfusions, and he was the first to do automated red cell exchange in Nigeria for sickle cell disease. And so we are so delighted that he's here. Currently, his professional roles also include the Secretary of the African Bone Marrow Transplant Society, and he's the Director of the European Bone Marrow Transplant Society for Nigeria. I want to make sure I did not leave out any of the speakers. I believe I captured everyone.
Those here present, I believe, yes.
I believe so. And if any of the other ones arrive, please let us know.
Okay.
Okay, so let's get started with our panel. And I don't know if there's a way to spotlight each of the panelists for
say who you want, and they will spotlight the speaker.
Okay, that's wonderful. Okay, so my first question actually starts with Professor Olopade. We just heard a masterful presentation from Dr. Makani, and she made this case that sickle cell transplant gene therapy is possible in Africa. But she mentioned why it's important. She said it's because we need to understand that Africans are not just a homogeneous group. We're very heterogeneous. Can you tell us what your current research, what does the current research tell us about outcomes in transplant and gene therapy in diverse populations, especially those from Africa? And how do we take into consideration genetic variations across populations?
Yeah, thank you very much for that, one, kind introduction, and two, allowing me to take the first question, because I must apologize. I work in Chicago, and I want to rest on all previous protocols because I see my colleagues who are distinguished professors of hematology on the call, and I want to thank the Sickle Cell Foundation for this wonderful panel. So one of the most important things that I think sometimes gets lost in medicine is that innovation always makes us do better. And so leaving medical school in Nigeria, my dream was to study sickle cell disease as a genetic disorder. Coming to America, I trained to be a hematology oncologist. So in the US, you train as a hematology oncologist. And we've been doing bone marrow transplant to cure many patients with hematological conditions. And we've been using immunotherapy to boost our immune system so that we can cure cancer. And if you actually believe in science, which I'm hoping that all of us now, especially since even in the US, we may have some who doubt science. I think the triumph of science is that we knew about sickle cell disease ages ago. It was described in a medical student in Chicago. And it's taken us so long, since 1957, to get to this moment. So I would challenge us that we know how to do bone marrow transplant. We know how to treat patients with sickle cell disease. We know how to give children prophylactic penicillin. We know how to vaccinate our children, but we have never had the political will to do so. So I am currently serving as the chair of the Nigerian Health Research Committee. And as a chair of the Nigerian Health Research Committee, I am hoping that all of you who are stakeholders will demand that the Nigerian government step up to take care of patients with sickle cell disease. It's not rocket science to do bone marrow transplant. It is not rocket science to do clinical trials. And so, having trained as a hematologist oncologist, I have been humbled to work with hematologists in Nigeria. And I want to give a shout out to Professor Duro Simi in Ife, who was the first to do a Novartis trial of Glivec. Glivec was a disease that we used to do bone marrow transplant for patients with chronic myelogenous leukemia. And once you could make that diagnosis in Ife, everyone got access to Glivec. That's why I'm hoping that this is not a hype. This is really a hope that we will do clinical trials in Nigeria. We will follow on the beautiful work that's been done in Tanzania and in 7 countries that I happen to be the chair of and advocating for everyone in the diaspora, because we have African Americans, we have Caribbeans in London. All of us are really one human race, and we need Nigeria to step up and do this work. So I apologize if I have taken too much time, but I have to go to clinic. And that's what I have to say is that the stakeholders at this meeting have to demand, because we can do it. It's not rocket science. Thank you.
Thank you. I want to just emphasize that we know better, so we need to do better. And I just appreciate you kicking us off with the right tone. And I want to take it next to Professor Adekule, because Professor Olopade just mentioned several important issues, and she discussed the dynamics of our ancestry as well. So I want to lean more into this question. You've studied sickle cell disease in both Africa and the Middle East. and you've looked at several different types of populations. Do you think that the genetic variability should influence the way we think about these new therapies, knowing that we want to get them? How should we approach them?
Well, thank you very much. That's a very important question. Now, I've been very fortunate in my career that I started as a clinician and then had the opportunity to do molecular genetics at the laboratory level for several years before I went back to clinical work. And again, I was fortunate that I could spend so much time in the Middle East, especially in Kuwait, where, the kind of variant of the sickle cell disease that we deal with predominantly is a little different from what we see in Africa and other parts of the world. And, we describe the so-called haplotypes, the Arab India haplotype, Benin, Bantu haplotype, Senegal, and all that. And we've used that over the years. But now, with new knowledge, we're even seeing that there's still so much variation within those so-called haplotypes that we really have to go back and rethink what these things really represent. So that just tells you that with more knowledge, more variability, being exposed, and that just tells you that whatever clinical trials we want to do, if you don't involve individuals from different regions, you'll be missing out. And that has been ably demonstrated with what happened with voxelotor, that was approved and, was being rolled out. And the time it now started being used among, African patients, several severe adverse effects showed up to the extent that this was discontinued. Now, talking about fetal hemoglobin, we know that it affects the physiology and the pathogenesis of sickle cell disease, because the more fetal hemoglobin you have, the more soluble your deoxyhemoglobin S would be, okay? Therefore, among patients that have predominantly, high Fs, and when we talk about high Fs, we're talking about 20% and more in individuals who have not been exposed to hydroxyurea or other, therapeutic intervention. And those patients tend to have a milder disease. But even then, the mild phenotype that we see associated with high hemoglobin F is actually predominantly in childhood. In Kuwait, for instance, the children do not present with their first symptoms until about 3 to 4 years of life. We don't see stroke at all, or very rarely. We don't see leg ulcers, okay? However, as they grow older into adulthood, we start to see end organ damage. And as a matter of fact, the adult sickle cell patient in Kuwait or even in Eastern Saudi Arabia is as bad as patients with low hemoglobin F. But in terms of conducting clinical trials in those areas, you have to be careful what your end points are. For instance, because of the high F, we do not see severe hemolysis. Therefore, the hemoglobin levels are in the upper region, 9 to 11 grams per deciliter. Therefore, if your endpoint was going to be anemia, and you're going to be expecting to see hemoglobins of 5 grams or that kind of thing, you would not see them. At the same time, the other really common complication that we see in that population would be avascular necrosis of the femoral head. Therefore, you really have to know the pattern, the natural history among your patients to be able to design appropriate clinical trials. There's no other way, but you really have to understand the kind of population you are dealing with. Thank you. I think you are muted. We can't hear you.
Thank you so much, sir. That was very helpful for us to appreciate the various levels of things we need to think about when we go into clinical trials. And so I want to move our direction back to the clinical care space. And I wanted to see if Dr. Akinshete is able to unmute. Okay, I see him now. Dr. Akinshete, this next set of questions is for you. In your view, is it realistic to scale transplant in low and middle income countries?
His name. We're two Dr. Akinchetes.
Oh, I'm sorry.
Yeah.
I should have apologized. Please forgive me.
No. I'm just teasing. We get that a lot. We get that a lot.
Okay, please say your name correctly, sir.
No, I'm fine. I'm Adeshe Akinshete.
Okay, I apologize. And I would love you to discuss for us whether you think it's realistic to scale transplant in low and middle income countries. Both Professor Makani and Professor Olapode said, yes, it's ethically our responsibility to do so, but is it realistic? I would love to hear your thoughts. And then because you are the transplant leader in Lagos, I wanted you to also share a lesson you've learned from your experience.
Yeah, thank you, Dr. Fashikwe. Thank you to the foundation for having me on this panel. So I agree with Professors Olopade and Makani that we can actually offer curative therapies to the people that we give care to, especially those with sickle cell anemia. However, I know that some of the things we need to navigate would have to do with if you look at the ecosystem for transplant, almost every material that you utilize, you have to bring from outside the continent. You really don't have anything manufactured within the continent. So I think that for us to be able to scale this intervention to the point where it's actually accessible and affordable to the people, we need to figure out that support infrastructure, the medications, the consumables that are utilized, and also to domesticate such things as HLA testing, chimera follow-ups, and all of that. Once we can get those, support infrastructure into the continent, and those things are reagents, consumables are manufactured in the continent, expertise is within the continent, I think you will see a drastic fall in the prices of curative therapy that we offer to people in Africa. I mean, we've looked at, if we just look at patients we manage for pediatric oncology, we've published experiences where for a fraction of what you get to pay in the West, you achieve the same outcomes for things like acute lymphoblastic leukemia. I mean, less than 10, 20% of the cost in the West. And that's because a lot of what you would require are very cheap and they are affordable and accessible within the ecosystem. So that is the way to go. I believe that, this kind of forum gives the opportunity to bring the people in financing, the NGOs, professional bodies together to the same table to fashion out a strategy that makes it available and affordable as well as accessible to the people. My experience in Lagos, I think that the most touching for me was one of the young ladies who actually cried because she exclaimed that she will no longer have to live with a life of pain. I feel that was a profound experience for her because it just dawned on her that, look, I've been in this journey 1 month, 2 months, 3 months. I've had this transplant and I've not had pain. And it brings home to us the things we take for granted as clinicians. You know, we see them in clinic, they're there in pain. We think we just give opioids and they're fine. But that pain damages them for a long time. So if just for that reason, I think we should try to make curative therapy as affordable and as accessible to as many of them as we can afford. Thank you.
Thank you so much. That was well put. And thank you for sharing the story of your patient as well. I want us to do a historical perspective. Professor, we have in our presence the excellent Professor Nosakari Bazuaye, and I apologize if I did not say your name correctly, sir. You started this in 2011. You've seen time pass since the first sickle cell bone marrow transplant. Can you tell us some lessons from the challenges that you experienced that we should keep in mind for today?
Okay, thank you very much. I hope you can hear me.
Yes, loud and clear.
Thank you. My in-law.
Now maybe this.
Thank you. I appreciate your coordinating this program and also inviting me. I didn't know that my in-law is poetic. So it's nice to hear that you can make a lot of, give us a lot of poems. I want to say that first I wanted to correct an impression that I'm no longer Chief Medical Director and Deputy Vice Chancellor of Igbenedion University. I actually did my 4 years, ended up last year, so I'm currently back to the University of Benin Teaching Hospital, but I'm also on sabbatical at the African Medical Center of Excellence right now. Yes, I also want to say too that it's nice seeing Julie. Julie, I consider her as my sister from another mother. And the last time I went to Tanzania, I had to stir up a little challenge in them. And I'm glad that Tanzania is actually doing bone marrow transplants and a lot of work is going on in Tanzania. So with my experience, to pioneer a medical excellent procedure in developing countries is actually very difficult. Actually, in 2009, it was published that it was difficult or almost impossible to do transplant in most low, medium-income countries, worse in places like Nigeria. So my lesson is that it was difficult, and as mentioned by Dr. Akinshete, we do not have all the facilities we have in this field of practice. So we rely a lot on foreign drugs, equipment, and then I didn't have all the equipment, but I was privileged to also be a JC inspector. So I had to follow the minimum bench standards. And that was a problem they had in Ghana. You know, when you start a program that is high-tech, you need to know your limitations. You need to start with patients that are good. And that's my advice to where we're going to start gene therapy in Africa. To say that when we're starting, we need to start with good prognosis. We need to select our patients properly. Ghana has a very beautiful, fantastic transplant center. But today, Ghana is not included in the countries doing transplant for bone marrow. Because about 4 or 5 years ago, they started bone marrow transplant and they started with haplo. And they had 4 transplants and they had very bad results. And so the center was closed down. So my experience is to say that, yes, we started very slowly in 2011. I also want to emphasize the need for public-private partnership. You discover that Lagos, who started doing transplant in 2024, the process started about 10, 15 years ago. And initially it was just by loot. And then it didn't materialize until kudos to the National Sickle Cell Center who joined. And that actually gave the kind of collaboration we're talking about. And even the government of Lagos also helped a lot. So governments, I've talked about not starting properly. I'm also talking now about the collaboration with terms of private-public partnership. Now, Tanzania has a lot of support from government, which we do not have in Nigeria. I must say that federal government may not be doing much to take sickle cell as a matter of priority. In about 5 years ago, we started to put a proposal before the National Assembly to see if sickle cell can be made a disease of significance because we have the highest number of sickle cell in the world. But that preparation got to second reading and it never passed. We're asking for sickle cell to have a better attention. All the research that is done for sickle cell and all the progress in therapy for sickle cell are done outside Africa. Meanwhile, Nigeria or Africa parades the highest number of sickle cell in the world. So what we're talking about is that we need to do more research in Africa. And that's why I'm actually happy to that some policymaker like the former governor's wife is here. She has done a lot, but we're talking about advocacy. I remember that I spoke to the wives of all the first ladies during the time of Buhari. And my proposal to the first lady was that if all the first lady sponsors want transplant patient for sickle cell in a year. So we have the first lady of the country. So there's a lot that government needs to do in terms of collaboration and funding. So if we're going to gene therapy, I want to say that it's not, these therapies are not beyond Africa. It's not a hype. There's hope that we're going to do that. But as I said, we need to do it systematically. We need to start taking patients and doing procedures with gene therapy and research to know that we can start gradually, but we'll definitely get there. To finally conclude, I want to say that it's possible to do all these things in Africa, but health insurance is a big problem. And I want to say that those who are in charge of policy making, once we get our health insurance right, Nigeria will do a lot, and even Africa will do a lot in terms of research and therapy for both sickle cell disease patients and even the healthcare facilities itself. So that's my summary, and I hope to take other questions if there's any. Thank you very much.
Thank you so much, sir. That was so instructive, informative, and I think it's making us pause to make sure we do this the right way. I love how each of you in your comments, you're referencing the patient at the center of this goal. And you also mentioned the people who are the champions. And with that, I want the next question to go to Her Excellency, Dame Edith Okoa. You know, she has done so much great work, and she's also interacted with families. I wanted to see, in your perspective, ma'am, have you seen successful partnerships between NGOs and public health systems that you feel bring real change? And then how do you think patients are perceiving these therapies? We would like to see an inside look to their perspective. Thank you.
Good afternoon. I want to appreciate Dr. Akinshete and the Sickle Cell Foundation, Lagos, for what they're doing. First, I will say that we've seen patients have not seen. They have heard, they have read. And I believe that many of these patients have hope, but so skeptical. Reason is, yes, they have heard, but they have not seen. I've had so many of our resource persons talking about successful cases. I appreciate it if such cases are brought in such events to testify about what has happened to them. Because you find out that people will want to go into such interventions if they see successful cases. When it's a matter of you hear, you read, no person will take a risk. Again, there is this fear and the cost. Many of the sickle cell patients are really not too buoyant with money. Some of them are struggling to eat. So I don't know where they're going to get the resources to go in for such a transplant. They're talking about collaboration between NGOs and government. That is what we do in Delta and the O5 initiative.
Yes.
We have newborn screening in all the central hospitals that we provided, the foundation provided for them while I was in office, which government has also sustained. The government also helps us to train genetic counselors that are there for the patients any time they go for their clinic days to talk to them what to eat, how to take care of themselves. I'm talking about the newborn screening. This newborn screening help us to catch them young. So we're able to take care of them. So you find out that many of them live better life if it is noticed on time than the ones that are already maybe having complications before they bring them to clinic. So to a large extent, like the last speaker has spoken, it is my prayer that government will show more interest in what we're talking about. That is the intervention for permanent cure for sickle cell patients. Thank you.
Thank you, Dame Okoa. That was so beautifully stated. And I can't emphasize enough the way you said the patients have seen, but they have not touched and experienced. And we are trying to, this is what this entire program is about. This is what the work of the several excellent clinicians and researchers on the call today, what they've been striving for. They don't want it to be seen and not touched, but we want to make sure people can experience this for themselves. Thank you. I wanted to go next to Professor Akinola. You know, Dame Okoa brought up several issues about the fundamental basics of sickle cell care, newborn screening, getting into preventive medicine. Do you think that the excitement about gene therapy and transplant, all of these things, do you think we're focusing on the wrong thing? Are we shifting away money, funding, resources from basic care and prevention? How should we balance this? How can we have the shine and the basic? How can we have them exist in the same ecosystem? Thank you.
Yeah, thank you very much, moderator, for this question. It's an interesting question because it's asking me to put my neck on the line here to say that, no, don't go there or remain with standard of care. No, but the problem is this is science, and science starts from one place. And it takes time to actually evolve to your endpoint. And here we're saying gene therapy is the endpoint over and above bone marrow transplantation. So we have bone marrow transplantation, but it even took us a while to get there. So what I'm saying is it's new therapies are things we should look forward to and plan for. All the speakers before me have emphasized that there's a need to start from somewhere. So starting from here is not too early. And, you know, you need to have a good bone marrow transplant setup to be able to do gene therapy effectively, because, you know, you're still going to condition your patients, even though it's autologous, it's like an autologous transplant. So people must be efficient and proficient in the management of patients in bone marrow transplantation before they can go into gene therapy. So that is a thing that we must work on. So I want to congratulate the Sickle Cell Foundation Nigeria for collaborating with Luz and the government of Lagos to starting bone marrow transplantation in Lagos, in addition to what Professor Bazwaye is doing in the main city. We in IFE have always, we have started something, but it's taken us a while to get there. We're still at it, but we started with HLA typing, tissue typing. And, you know, before you can say, yes, you want to go and transplant or give gene therapy, you need to be, let me limit it to transplant. Yeah. You need to have a compatible sibling donor, 100% preferably. So to reduce risks, just as Professor Bazwaye said earlier, you must choose your patients. Now, we've talked about the genetics of sickle cell disease. Professor Olopade mentioned that there is a variation in genetics. And we see that even in the clinics, where we have patients with sickle cell disease, those with mild disease, those with moderate disease, those with severe disease, sometimes irrespective of their fetal hemoglobin, as Professor Adekile mentioned, that even patients with high F can still have pains and still have complications of the sickle cell disease. So it means that the genetics are still there for us to investigate. So we have work to do in this area. In addition to getting ourselves prepared to attending to the complications associated with bone marrow transplantation. Remember, not all patients need to be transplanted. Yes. Not all patients need gene therapy. In my clinic, once we started hydroxyurea treatment, which is the standard of care recommended for sickle cell disease now, we find that most of our patients who were in severe category have come down to moderate to mild disease now. And they say, no, they don't even need bone marrow transplantation, that they're happy where they are. So if we're able to master the use of hydroxyurea, which is what we have at hand for now until a new therapy comes up that can be more affordable and easily accessible to our patients, we should ensure that we find ways of making hydroxyurea available to our patients, especially to those who can't afford it. So this is where PPP collaboration also comes in. My NGO has collaborated with other NGOs to ensure that mothers get funding or get the drugs they need for their babies. So from newborn screening, you screen babies, diagnose them early, you put them into care, comprehensive care. If they don't have hydroxyurea to add to their care, then, well, it's a waste of time. So to help them to live quality lives and to reduce the mortality rate of under 5s with sickle cell disease from 50 to 90% to near to zero, we need to ensure that hydroxyurea is part of the comprehensive care management for our children. So bottom line is, gene therapy is at the end of the continuum. There are things we need to put in place in between hydroxyurea and gene therapy. And the more we collaborate together to ensure that we improve the care and quality of life of our patients, the better for us all. So together we can get cure for sickle cell disease. It is not a hype, there's hope. Thank you very much.
You, Professor Akinola, that was, I'm just getting so many gems of wisdom from this program. Professor Akinola, you said that the continuum. So we need to be looking at everything as a continuum and implement structures so that we can provide the basic prevention as well as invest in the science and our future. Thank you so much. And so let's go to the hard question.
Sorry,
Yes, please.
You have Dr. Gaurav on the call now. He's on
I
the screen.
do. And so I was going between Dr. Gawa and Dr. Wellington, and I can actually introduce him now if he's available.
Policymakers.
Yeah, let me introduce him. So you heard earlier on the call that we have people from various countries that have called in. Well, one of our panelists is actually calling in from India, and that's Dr. Gaurav Karia. And we are so delighted to have him. He's a renowned pediatric hematologist and oncologist, and he's also the director of the bone marrow transplant and cellular therapy unit in his hospital, Fortis Memorial Research Institute. And this is in Delhi. He has been doing transplants for several years, and he's completed over 700 various types of transplants. And he really has a passion for sickle cell disease and other blood disorders and cancers. One of the things that we found very fascinating is that he combines that technical expertise with the compassionate care. Again, he puts the patient first, and this has been shown through all of his happy patients who have received the therapy. And so, Dr. Karia, I had this question for you. I wanted to know, in your context, you're working in India. This is also a society that has a balance between that low middle income experience. What lessons can we learn here in Nigeria about India's approach to addressing the socioeconomic disparities when it comes to accessing therapies like transplant? And how do you feel about the ethics, the dynamics of prioritizing patients?
Right. Thank you, Dr. T, and thank you, Dr. Annette, and the entire Sickle Cell Foundation Nigeria for having me here and for this wonderful, very, very, very interactive and very useful, very pertinent sort of brainstorming session. So just a small correction. Basically, I work as a director center for bone marrow transplant and cellular therapy, Apollo Hospitals, Delhi. So that's my affiliation. I'm not at Fortis Institute. And secondly, I also work as a founder and director of one startup which is dealing entirely to come up with affordable state-of-art cell and gene therapy solutions, which is called as Cellogen Therapeutics. We have just got our global patent for our first bispecific third generation CAR T cell in the world. So this is the first bispecific third generation CAR T cell of the world to treat B-cell malignancies. And we are also in the process of filing our patent for are gene therapy for thalassemia and sickle cell disease. And that's a very innovative approach. And the whole objective here is to sort of make it or provide these state-of-art therapies in a cost-effective manner. Now, this gene therapy is sort of an extension of my work, which I've been doing for past almost a decade on sickle cell disease. A brief about how I developed interest. So I basically, you might be aware that following Nigeria, India has I think the second and or third highest burden of sickle cell disease in the world. So these three countries put together, Nigeria, Congo, and India, form almost 1/3 of the population. So in India, I belong to a place which has a huge, significant sickle burden. And rather, in my MBBS days, I remember we used to have a separate ward which was dedicated for sickle cell disease patients. And in those days, unfortunately, in India also, we are not being able to offer anything beyond the routine analgesics and hydroxyurea. Now, that was one side of the story. Subsequently, after getting trained in India, I moved to UK and worked at Imperial College for some time. And that was something which was a turning point when I thought that, no, I need to take this as a task. So I moved back to India and started the program for sickle cell transplant, like overall transplant, but with a major focus on sickle cell disease. When I started doing transplants for sickle cell disease, which was around a decade back, hardly in India as a country, which is a huge country, approximately 20 to 25 transplants were done all over the country in past 30 years. So I took it as a task, and I thought, let me start the transplants for Indian patients and also for patients from other resource-limited settings, such as Africa. To start with, there are a lot of challenges which anyone can imagine. I mean, first of all, the biggest challenge in sickle cell disease transplants is to have a clear set of indications for transplant. I mean, that still is the most difficult task. Which is the right candidate for transplant? And what is the right time to take that patient up for transplant? Now, to summarize this, I think what I always quote is one-liner from Dr. Shalini Shenoy's one of the very beautiful review articles that just like any other non-malignant disease, transplant for sickle cell disease should be done in early stages in anticipation of a impending end organ damage, because once any end organ damage sort of happens or is setting in, then that significantly brings down the outcome of sickle cell disease transplants. Now, that is what I have been sort of advocating. To start with, it was a very difficult task because we used to get the patients who were very symptomatic, having 2 or 3 organ dysfunctions, multiple criteria fulfilling bone marrow transplant, and beyond a certain age. And as we all know, after the HLA typing, the second most important factor which decides the outcome of transplant is the age of the patient, which varies in different parts of the world. Like in Europe and US, people say that 13 to 15 years is the cutoff, whereas what we have realized in India is like that cutoff comes down to 10 years. So to sort of make people aware that we need to identify the patients early on and take them up for transplant early on is the best possible way of minimizing the transplant-related complexities, maximizing the outcomes, which can be as good as 95 to 97%. And obviously, if we do it early, it is quite cost effective. Now, coming to the question of how to make it cost effective. Now that's very important, and I personally feel that I was fortunate to start it in India because we have access to a number of drugs which are manufactured locally, and I think that makes makes a significant chunk of the overall cost involved in the transplant. So I think we need some little bit of better collaboration there, that the drugs which are available in India, manufactured in India, can be brought to African countries in a cost-effective manner. I think that will significantly bring down the cost of transplant, because almost 1/3 of the cost of transplant is the cost of these drugs which are required for transplant. Apart from this, I think it's all about sort of a escalation of your transplant strategies, as has been highlighted by Dr. Bazwai and others as well, that you should select your patients not only to build your confidence, but to build up the confidence of the entire sort of community that yes, this is something which is very much doable and doable in different parts of the Africa. As rightly mentioned by the previous speaker, it's not a rocket science, but yes, it needs a lot of commitment, a lot of devotion, and a lot of hard work and experience to sort of optimize these outcomes. We are still sort of in the process of optimizing it. Over a period of time, we have made significant progress. Almost 200 transplants we have done just for sickle cell disease with different sort of outcomes. But we recently analyzed our data, and approximately out of 197 transplants which we have done, the outcomes are now overall, if we say, are around 85%. The outcomes were not good earlier because of different reasons. We're not getting the right set of patients. There were other challenges, but if we say the outcomes, look at the outcomes in the last 3 to 4 years, they've significantly improved. And not only because we get the right set of patients, but also we have learned over a period of time that transplanting a patient from US or UK is very different from transplanting a patient from resource-limited countries. So I think these are some takeaway lessons for transplant, and we are trying to replicate the same for our gene therapy work also, which we are doing.
Thank you so much for sharing your experience, and congratulations on the patents and all the work that you're doing to bring innovation to this space. We appreciate hearing from you. I'd like us to go to Dr. Wellington. Oh, yes.
So, sorry, indulge me, please. I'll just looking through the list of panelists, and I think we have only the policymakers left.
Yes.
But I think it would be remiss of me if I do not, in this platform, speak to this therapy from my classmate, Dr. Nusa Amoigui, who is in the class. You've heard about, so the clinicians now on this call, you've heard about the golden half-hour oxygen therapy that makes a big difference, and many patients are speaking to the efficacy, effectiveness, and so on. So perhaps you should speak to it, Dr. Fashikwe. Have you heard about it, and what do you think it does? Because we in Nigeria, we're just beginning to hear about it, and it hasn't really gone through trials here.
I think similar. You're talking about hyperbaric oxygen therapy?
It's a home-based oxygen therapy in Rochester. The golden half hour. In other words, within 30 minutes of the crisis pain, PST commencing.
Maybe because I'm in the pediatric hematology space. Yeah, okay. I'm in the pediatric hematology, so I don't have as much experience myself.
Okay, so Akinshete, maybe Professor Fakile, Professor Adekile. Someone should fill that question.
Well, you know what? I've come across
oxygen therapy, home therapy.
Sure, I've come across snippets of kind of anecdotal, publications, and not even in. Well, mainly in the lay press. Let me put it that way. I'm personally, because several patients have contacted me about this, but honestly, I'm still waiting to see evidence that has been published of a trial, that is well conducted before I can comment on it. I mean, that would,
Can we do that trial ourselves here? Can we do it, or we have to wait for Dr.
No. I mean, no. There's no reason why the trial can't be done anywhere. I mean, once it goes through the usual, ethics clearance, just do it a proper trial and get it published. Because look, okay, we all know that to prevent sickling, you want to prevent hypoxia and all that. But when it comes to therapeutic interventions, I mean, we use oxygen therapy in the hospital. I mean, for patients who have impending or established acute chest syndrome, for instance, you monitor their oxygen saturation, and you don't want it to go below a certain level. And when it falls, oxygen doesn't even help at that point. You do exchange transfusion quickly,
No,
you know.
before when you're at
Okay,
home.
see, now the question then, but let's just put it this way. Let's design a good study,
Okay.
you know, and carry out a good trial, you know, because it makes sense theoretically,
It does
you
make
know,
sense.
but yeah,
And some patients are, swearing by it.
sure.
Okay, sorry. Moderator, please carry on. I just thought to put it before we go to the policy makers.
Yes, this is in the spirit of this conversation of what is the definition of innovation in sickle cell disease, and what are all the components of bringing good care to sickle cell disease. So no, thank you so much. I wanted us to before we head to our questions, because we have lots of questions from the attendees. I wanted Dr. Wellington, yes,
Yeah.
I wanted Dr. Wellington to discuss about the public health standpoint. One, what are the policies and partnerships that should be considered as we try to get these advanced therapies for sickle cell more accessible? And from your viewpoint in the public health arena, how do you balance that cost effectiveness question when you want to invest in the advanced therapies, but you also, as Professor Akinola reminded us, and Dame Makoa also, we want to also remember the preventive medicine component too. So please, we would love to hear your perspective. And please unmute, ma'am.
Okay, you once again, Sister Foundation for having me here. And I'd like to say kudos to the speakers and then the other panelists that have spoken before me. This is okay. Let me just dive in. I mean, we'll talk about the kind of partnerships that we think would really help making all these advanced therapies much more accessible locally. I think we'd like to consider some sort of technology transfer or local production of all this. And just like Professor Bazwai and Dr. Akishete did say earlier on, I mean, a lot of the materials that are used for a lot of these advanced therapies are not popularly, they're even available. They have been and they're expensive. So if we have things like technology transfer, local production partnerships, really help to improve availability, drive down costs for this material. We also look talking about tiered pricing and market shaping mechanisms. I mean, there's a way you can consider the users of these materials and providing them, considering the economic capacity of the nations that would like to patronize and not necessarily give us at a market cost or global pricing. And then another thing I think would really help is if we look about the regional centers of excellence that we have in Abuja and we have in various countries in Africa. If there's a way we can, optimize the regional centers of excellence and of course collaborate amongst themselves to also help, in capacities to be able to provide all the advanced technology interventions. Another thing we can look at is in research and clinical trials partnerships. It opens up. I mean, I remember Professor Matani did talk about the fact that even though we're talking about a lot of these therapies, some of them are not exactly tailor-made, not particularly suit our environment. We need to actually develop population-specific interventions. And when this research and clinical trial partnership will also help to be able to bring these interventions to the environment, making sure that we develop the that specific for our needs, and then be able to also drive the costs and improve access. Also do look at countries, I mean, like India, like South American countries that have our kind of unique issues. I mean, talking about our sociocultural beliefs, our the population, the kind of socioeconomic factors that we have, and then we can learn from them. How are they doing it? How are they being able to actually address the challenges of this innovative therapy? Then, of course, one very important one, of course, is insurance and healthcare financing. Making insurance and healthcare financing very, very available to people, making sure that we have insurance that people can afford and that it is mandatory and then available for people to be able to utilize. The other thing that's international finance, developmental finance structures like the World Bank or the African Development Bank. If you can get financing from such institutions to be able to fund all the strategies. Now I'd like to actually go back to what Dr. Aksheta said earlier on about equity without innovation is indeed inadequate, while innovation without equity, it is truly immoral. I mean, talking about coming from the public health perspective about trying to balance, oh, do we go for the advanced sickle cell therapy or do we go for the basic care that we have? We have to balance our population and the impact of this intervention on population and equity. Expand these basic services that we have now, talking with the screening programs, urea, pain management protocol, preventive care being provided, and things like that. Against talking about the gene therapies and marriage and things like that. We have to understand the fact that a lot of the basic services that we have, even though we will say affordable and access is improving every day, but for some people it is still quite expensive. I mean, balance that against the innovative therapies that are quite expensive, very, very expensive, and would only benefit just a small number of people at present. Now, looking at the cost-effective analysis, I mean, like I said earlier on, we have to balance. We have to understand the fact that, yes, the resources are there, but they're actually finite. They're not exactly infinite. We have to find a way to balance how we spend the resources that is available. We have to make sure that we reach as many people as possible, even with the scarce resources that are available. So we need to be able to make sure that the people that need this, we get them. That is available, that can easily reach them. That's again ones that we need to spend so much money on reach a number of people. We have to look at the health capacity. What do we have? Can we handle presently? I mean, I look at it, the basic care that we provide for sickle cell now is like the foundation for whatever advanced care we're looking at providing in the future. We need to get it right from the foundation level. We need to be able to provide the basic care effectively as it now. That is something we're still struggling with. We're still talking about adjunctive therapy is still not optimal. Bone marrow blood transfusion is still not optimal. Getting the routine medication, getting the antibiotic, getting the vaccination is still suboptimal. We need to be able to maximize these therapies so that those can stand as a foundation and the bedrock for much more advanced therapies in the future. Then we should need to be able to actually sustain what we have on the ground. That's very key. We need to be able to make sure that the care services that we're providing in our resource-limited environments, that we're able to actually be able to sustain when these services are needed, they are available. And then, I mean, I would not say that just because we're trying to reach as many people as possible, and care that they need, that means that we should just totally throw away advanced therapy. You know, like I said earlier on, our basic services will serve as well as the foundation for us to be able to improve upon and bring on much more advanced therapies. Because if you do not have a foundation, you cannot build on it. So, I mean, both of them, we have to find a way to balance it. We have to make sure that we get it right from the beginning so that we can build on it. So definitely, the two of them, but we have to do a kind of stepwise approach. It has to be balanced. We have to get it right first. We have to be able to provide the basic care effectively first. Then we can move on to much more advanced therapies. Thank you. I'd like to repeat, equity without innovation is inadequate, and innovation without equity is truly immoral. Thank you.
Thank you. And thank you for reiterating those words. And just while we're on this topic, since you may have more experience with this, the National Health Insurance and Vulnerable Group Fund for Nigeria, do you see this as a potential pathway to help patients with sickle cell disease get access to preventive care? Dr. Wellington?
Yes, it is actually. I know that in Lagos State now, we have been in discussion with quite a number of partner patient supports in trying to get tailor-made and specific health insurance package. I'm talking about the Lagos State health insurance package. We have a state health insurance package that is called the Lera Eco, and it's open to all Lagosians to be able to access quality healthcare services. And then we also recognize the fact that sickle cell warriors, they do require this service. It's much more frequent than some might, but I mean, we recognize that fact. And the state is in discussion with some patient trying to find a way to access this health insurance packages at affordable rates for them. I mean, providing good discounts and then even providing some support in additional numbers of people that can recover insurance. But that's one of the things that we're looking at in the state.
Thank you. Thank you for
Insurance would help in improving access, definitely.
Wonderful. And it's good to hear the Lagos experience and the Delta State experience as role models for all of our states here in Nigeria. And so I first want to ask everyone to, whether silent or with the reactions, please give a hand to our wonderful panel before we take questions from the audience. I have been so inspired and encouraged. It makes me proud to not only be a Nigerian, but to be living in this time period that we can witness this innovation in real time. It's quite a gift. And I want to thank those that have poured their blood, sweat, and tears into making these things become a reality for individuals in Nigeria and sub-Saharan Africa and the world. So there are several questions, and many of them are grouped under the same themes. I wanted to start with Professor Makani, Professor Julie Makani. You gave such a beautiful presentation, and I think there's some basics that some individuals in the audience want to make sure they understand clearly. One, what is the difference between transplant and gene therapy? Why are the transplant doctors talking about both? You know, is there some difference between them? And then there is a question about side effects, and maybe we'll allow one of our transplant physicians to answer that. But if you can start with the basics, just to recap for us again, the difference between transplant and gene therapy, or are they in the same family? And maybe oh, there she is, Professor Makani, go ahead.
Thank you. I'm just going to switch. Thank you very much for the question. So with a bone marrow transplant, you are getting stem cells from somebody else. So it's a donor who's giving you stem cells that go and replace your own stem cells to start making blood cells that are not sickled. So that's bone marrow transplant. When we are talking about gene therapy, you're getting stem cells. These are your own stem cells that are taken out of your body, like a blood donation, and then they are modified in a laboratory and then put back into your body. So it's a type of transplant that is called an autologous transplant because you don't need another donor. You're donating or you're giving your own cells to yourself. And so that's what is called ex vivo gene therapy, because the cells are taken out of your body, modified and put back. In vivo gene therapy, which is occurring in things like hemophilia, and this is what we're hoping to do in terms of hemophilia, in terms of sickle cell long term, is that you have an injection that then goes into your bone marrow and modifies the stem cells, so you don't have to take the cells out. So that's why it's called in vivo gene therapy. So essentially, ex vivo gene therapy is a type of transplant. In vivo gene therapy is a type of is not a transplant. Yeah. So in terms of similarities with regards to chemotherapy. So this is the medicine that you need to take when you're having the transplant. It's the same for ex vivo gene therapy and bone marrow transplant. The chemotherapy is the same. For in vivo gene therapy, the expectation is that there will be no need for a transplant, which is why we're hoping that in countries such as Nigeria or Tanzania, with in vivo gene therapy, essentially we would leapfrog and not have to have many transplant units and do ex vivo. We could just leapfrog. And I think Professor Fumi Olopade also talked about Gleevec, imatinib, and CML, where they moved from transplant for CML, which is a type of blood cancer, to just taking a medicine for treating the disease. Yeah.
Thank you. Thank you, Professor. That was a wonderful explanation. And Dr.
May I ask? Can I
oh,
ask
yes, please go ahead.
I'm sorry, I'm interjecting, but I'm looking
No,
at
this
the
is
time,
good.
and I would just like
Exactly. I heard we only have 10 minutes left, so I want
to appeal to you that you will just take one more question only, and then we'll sit back and compile all the questions that I hear in the chat. And so I'd really like to appeal to participants to drop their questions in that chat, and our team would compile all of them and give request responses from various panelists, which we will send. We will endeavor to send to those who have asked questions, because I know persons are maybe getting a little restless with the time. So over to you, please. One more question. I know that can I cheat and ask that
yes,
you
may.
Funsho Shobande, please, if you ask, his hand goes up if you're still there to ask your question before you leave, Mr. Funsho Shobande. Otherwise, moderator, take your. Mr. Funsho Shobande? Okay. I don't think he's there anymore. I don't think he's there anymore. You can carry on.
Okay, so why don't we end with this question?
Can you unmute? Can you unmute Funsho Shobande, please? Hosts, admins, unmute Funsho Shobande, please.
Okay, good afternoon, everybody. Thank you very much for all the various professionals, medical practitioners, and everything contributing to the success of today's events. Again, the key question we're trying to address today happens to be, whether these breakthroughs are really bringing real hope to patients, or whether it's hype for privileged few. And just a few thought-provoking remarks in addition to what has been said. I mean, the fact that we have all the breakthroughs and we have individuals who have undergone successful treatment therapies and life-changing improvements, and the ability to resume their normal duties at school or at work, including climbing Mountain Kilimanjaro. It tells us that it is possible to go through these therapies and live without constant pain and to plan for the future. Furthermore, for the first time in over a century, since sickle cell disease was identified, patients can now look forward to not just surviving, but thriving. And this is not the end of the story, but it may be, in fact, the beginning of a cure that's becoming a reality for all. And I think therein lies the hope. But then the hope has to be tempered by some of the other things that have been mentioned. One is the economics or affordability has a price tag in this context, definitely. And the price tag for gene therapy, probably close to $2 million, thereabouts, I don't know. So it raises the issue as to whether cost versus value, is this price justifiable? The upfront cost appears prohibitive, but there are a long line of chain of benefits to come. Then also in terms of the access, there is an access gap where, depending on your geography and depending on your income bracket, access can be uneven by race, by insurance status, by geography, and so on and so forth. But most importantly, I think what I want to emphasize here is the partnership between the healthcare systems and the financiers, to make these things a reality? Are the healthcare systems investing in the ecosystem that's required to make these therapies more viable for patients? What is the support infrastructure that's required? Where are the necessary insurance schemes? Do we have people from the insurance industry participating on this call? The pensions industry in Nigeria alone has over 23 trillion naira invested in it. And these claims will never be paid all at once. Is there something we could build or construct from there? You see, it's about the innovation and the developments in medical research and the breakthroughs being met with the infrastructure that's required to make it affordable, otherwise it remains out of reach. And I think finally, even though hope is powerful, it must be safeguarded from the hype because in the first instance, not all patients are eligible today, some due to health, some due to age or other logistics. Secondly, the long-term safety of all these therapies, because they are young, is probably still under some kind of review. And then the access in terms of global equity is not automatic. And so, yes, indeed, this is a moment of hope for all the new therapies combined, but it will only transform lives if we're able to tackle the structural, economic, and ethical barriers and take those head on and simultaneously try to put in place solutions that will make the therapies available to many. Otherwise, what feels like a miracle for some and those who are able to access it may end up nothing more than hype for many. So that's my 2 pence on the discussion. Thank you very much.
Thank you, sir. That was so well put. And with that, we will wrap up our panel. I wanted to say another thank you to each of the distinguished individuals that joined us today. And I'm going to just summarize the comments with my closing remarks before passing back to our host. And I just wanted to start back with Dr. Makani's words about, she set the precedent. This is an ethical responsibility. We need to expect more and demand more for Africa. And that includes transplant and gene therapy. And I love how we were then able to hear from Dr. Olopade. We know better, we need to do better. This is the same message. Professor Adekule reminded us about the genetics and the nuances of the African ancestry and how that contributes to research and clinical trials, and how that we should keep that in mind. Dr. Akinshete also now discussed that support infrastructure that is needed, and many of our speakers spoke to this. How do we actually make this a reality? By investing in that infrastructure. And we have to remember to keep the patient at the center. And before I finish my remarks, I wanted to emphasize people like Mr. Lukman Ibrahim in the chat and others who are patients listening today and wanting to join this conversation. And I hope the Sickle Cell Foundation Nigeria will be able to do maybe a town hall or a listening session to gather information from people who are impacted by the disease. And that brings us to our transplant physicians, Professor Bazouai and also Dr. Karia, and their experience seeing the challenges in the low and middle income countries to successfully making transplant a reality. They emphasize several points. We have to figure out how to know your limitations, as Dr. Bazouai mentioned, and really think mindfully about what it looks like to have public and private partnerships. Her Excellency Dame Okoa, and how she reflected on that patient viewpoint. Is this really a reality if I can hear about something but I cannot access it today? But we are doing the things to move closer to that future, and her work is one of the best examples of that in Delta State, and we're grateful to her, and we hope that other states will also take that model. Professor Akinola reminded us that we have to keep prevention and innovation on a continuum. It's wonderful to be excited about gene therapies, but we also need to do the essential things like hydroxyurea, penicillin vaccines, newborn screening. and thinking mindfully about how to drive down cost as well to make these interventions affordable for families who may not want or be interested in transplant or gene therapy. And then that brings us to our policymakers and those that are driving our government. When Dr. Wellington reminded us that we should look at these other models, we should think about investing in the cost-saving measures, as well as advocating to the private commercial spaces to also invest in this space, knowing that for us, sickle cell, as you've heard multiple times, the country having the most sickle cell in the world, Nigeria, this is our responsibility to step up to the plate and show that we can prioritize sickle cell disease in this way. And so with that, I would like to end by quoting again what Dr. Wellington quoted from Dr. Makani, Professor Makani: equity without innovation and the balance between innovation without equity, both are required for this journey for transplant and gene therapy. Thank you again for the honor of allowing me to moderate. As somebody who has sickle cell disease, this brings tears to my eyes to be part of something like this. And I'm grateful for the work of the Sickle Cell Foundation Nigeria and all of the organizations and institutions represented today. Thank you.
Wow. Thank you so much. Excellent moderator, Professor Titilope Fashikpe. I am so grateful to you. We are also grateful to you, waking up so early in the morning to join us on this call. You know, we are wonderful. And like I said, that side gig, we shall talk about it. Thank you so much. And I think it just remains, because time is fast spent, to add the call to action, which we must always have after all this interaction and talking. There needs to be call to action. But before that, I think we're all in agreement that it is not hype, HYPE. It is not hype. There is hope. It's not hype. There is hope. That is always innovations, new treatments, therapies, bone marrow transplantation, gene therapies, gene editing. They're not hype. There is hope. However, like we were cautioned by Mr. Fusha Shubande, let us temper that hope. Though there is need to temper that hope so that we're not over, stating our expectations. But for that call to action, and let me dial back. Before that, I think that all of these will be plowed back to government, because I tell you, government is very powerful. It's government that gives us direction. It's government that sets us on the path, which way to go. But we are there. We are here as non-profits, as advocates, to do the work for government, and we're ready. We don't even have, we're not fettered to the ground with all the encumbrance that government may have. We have the latitude to work, to mobilize funds, to do things out in the field. But government has to set us on the right path, give us direction, give us the policies, give us the guidelines. After all, the work of government is welfare, and health is welfare. So that call to action is one, to government, to policymakers, Dr. Wellington and co. The burden of sickle cell is not a medical inconvenience. It's not medical inconvenience. It is a developmental crisis. As you know, we talk about health as developmental. We don't look at health. In some corners, they look at health as a waste pipe, where it's like pouring money in a basket and all the money goes. But it needs to be seen from the perspective of development. Without health, in fact, have you heard that there are two problems in life? The first problem is health. The second problem is others. Is when one loses health that you now realize that others, there's nothing like one problem is health, the other is are the others. So please prioritize sickle cell disorder. That is just in a nutshell. Government should prioritize sickle cell disorder. But I see that we've come a long way, So, but remember what was done for HIV and AIDS, and what's still doing for HIV and AIDS? That level of concerted effort, malaria, tuberculosis. That's the kind of thing we should see for sickle cell disorder. After all, it's our own thing in Nigeria, in sub-Saharan Africa, it's our thing. So let's do the best that we can, and it's government that will set us on that path. If government does not prioritize it, nobody else will see it as priority. And that's, I'm speaking not just about Nigeria, but as for all countries in sub-Saharan Africa. Okay, so let's bear that in mind. To our sickle cell warriors, we call ourselves warriors. I beg to differ. I would like to say we're champions. So sickle cell champions, your courage is the curriculum from which everybody must learn. We need a curriculum like, syllabus. That syllabus has to come from those who have the condition. So please go out there and teach the world. We know where the shoe pinches, we teach the world. To our scientists, it's wonderful that we're doing all the work, and I really doff my hat for all of you. It's hard work. Some say that they're eggheads, but they're really brilliant. But all that brilliance, will come to naught if the findings are not applied in real life. So we've had meetings where they've said from gown to town, that is from the citadels of learning to the society. So we need to apply all our findings. So that's to our scientists. Those breakthroughs, let's look at them. They're like needles. Again, I'm waxing poetic here. That's the breakthroughs are like needles weaving and healing into our DNAs. Okay, but our scientists also sow justice into the fabric of our health systems. So you need to marry all of these. And then to advocates and caregivers, let what you have heard today, that we are all advocates, caregivers, let what we have heard today in this fantastic platform, like I've said, we have a powerful, a powerhouse of discussants. Let what we have heard today invigorate our resolve to continue to fight for positive change. And not just fighting for fighting's sake, fight smart, fight thinking, putting our thinking hats on so that we win, fight to win, fight smart, okay? So that's where I would like to say that our calls to action are. All of these, and there are more. And like I said, I promise we're going to plow back what has come out of this platform today to government to ensure that policy is developed around all of these things, and it makes it here. And that's not just the ministries and the executive, but also the legislature, so that they help us come up with bills and laws that will give bites to our policies. That's why we have the beautiful structure of democracy, and I hope that really make it work for ourselves. And it just remains for me I'll say thank you, but the main person to say the thank yous, it was going to be Mrs. Uwa Oipu. She's coming, but I want to speak Swahili to Professor Makani and say asante sana, and of course our languages besides English. Thank you very much. That good day. Wese goes to Professor Bazwaye. We do, and Oipu as well. We do. So these are the ones I know. But asante sana, Professor Judy Makani. Asante.
Asante sana. Bye-bye, everyone. Asante sana.
To you, please. There's still one more thing. We have to acknowledge two people, just a very young person. We know we have to carry our young people along. I like one statement, say there's no success if you don't have a successor. Those that are coming behind us. Medical student, she's a young woman, vibrant young woman, the president of the Medical Students Association of the University of Lagos. Modukbe, I don't remember you have an Ondo name that sounds Akin Bulire. Ondo, definitely. Modukbe, speak for 1 minute. I want you to show the world that young people are interested in all these conversations. 1 minute only, please, because time is fast spent.
All right. Good evening, everyone. Can you hear me?
Yes, we can hear you. Please spotlight Modukbe.
Okay. It's a pleasure to be here. My name is Modukbe Akimbilere.
Now. Yeah,
my camera is okay.
Okay, go ahead.
Let me
1 minute. We don't have the time.
Let me work on my camera.
Shoot. Go ahead. Time. Unmute yourself and go ahead, please.
All right. My name is Modukbe Akimbilere. I'm a final year medical student of the College of Medicine, University of Lagos. I'm also the president of the Association of Medical Students, University of Lagos. So it's an honor to be here, and I must say I am greatly honored to be speaking at this event. Today's event, titled Access to New Therapies, Hope or Hype, it's one of tremendous relevance, as all our speakers have said today. not only to the medical and scientific community, but to every Nigerian family touched by the reality of sickle cell. As a medical student, I've come to understand that medicine in itself is not just about what we do, what we prescribe. It's about how far we're willing to go to ensure that the knowledge and tools we have reach the very last person in the most remote community. And that's what today is really all about. Now, that's why this event matters so much to me and to my colleague, because it challenges all of us, both clinicians, researchers, policymakers, and students at large, to shift from potential to impact, from publication to practice, and from hope to access. Now, for we as medical students, being part of this platform is more than symbolic. It's a reminder of our responsibility to step beyond the walls of our teaching hospital and into the realities community. At AMSO, we are constantly mobilizing our members to be involved in meaningful outreaches, research, visiting rural areas, providing health education, screening, advocacy programs, because we believe that learning must be accompanied by service. We believe that our medical journey is not complete if we do not touch lives where it matters the most. So events like this not only expose us to new knowledge, they reinforce our commitment to ensure that science we learn translates into real change for people living with sickle cell disorder. So on behalf of myself and my fellow future doctors at large, I want to say thank you for creating the space for us to listen, learn, as well contribute. And even more importantly, to be reminded that innovation is only meaningful when it meets the people at their points of need. Thank you to every one of our speakers, and we look forward to the beautiful change the future of sickle cell care brings to Nigeria and beyond. Thank you very much for having me.
I know you're a final year medical student, but also resident doctors on the call. And remember that you have CPD points to benefit from this engagement. But then Funto of Investment One, important because you're our finances. Thank you, Funto. Come on board and give us a 1 minute remark. Funto, can we see you? Funto Sano. Take it away, please.
Can you hear me? Okay.
I can see you.
Good afternoon.
Hear you.
Good afternoon, everyone. Good afternoon. It's such an honor to be speaking here today at this incredibly timely, I'll say, and important webinar hosted by the Sickle Cell Foundation. My name is Funto, as has been said. I'm the strategy head at Investment One, and we're also glad to be sponsors of this year, one of the sponsors of this year's event. We're truly excited, to be honest, of this opportunity to partner with the foundation and to stand alongside so many inspiring professionals. I've been on the call for a while, and just hearing people advocate for those with sickle cell who are working tirelessly to improve the lives of individuals with the disorder is remarkable. Today's theme, access to new therapies, hope or hype, speaks to a critical crossword. It's a question not just about science, but also about equity, about access, ultimately about hope, hope that's grounded in research, policy, partnerships. At Investment One, while our core business is investments, as the name connotes, we also understand that investment must mean more than money. It's more than finance. For us, it's also about investing in people, in community, in health, in structures that allow people to actually thrive. That's why we're glad to support the foundation, its mission to raise awareness, drive advocacy, ensure that individuals living with sickle cell disease are not left behind, in the pursuit of medical advancement. As financial partners, even to individuals and institutions alike, we see firsthand, the long-term impact that health challenges can have on families, businesses, communities. We also see how access, whether to healthcare or financial tools or investment education, can completely transform a person's outlook and opportunities. Our belief is simple, sustainable progress happens when sectors collaborate. Healthcare, finance, education, technology must all come together, to build these systems that are resilient, inclusive, and future-ready. Investment One, as it is committed to being part of that collaborative ecosystem, supporting innovation, empowering lives, helping to bridge the gap between possibility and reality. We're particularly proud to support organizations like the Sickle Cell Foundation that lead with vision, credibility, and compassion too. The work you do quietly, consistently is nation-building work, to be honest. And interestingly, today is Democracy Day in Nigeria, and it deserves not just recognition, but real ongoing partnership. To everyone participating today, I say thank you for the work, you do. but the questions you asked, but the lives you touch, and we look forward to learning from all the, discussions, the outcomes of, and to continue supporting impactful work in health, science, human development in Nigeria and beyond.
Thank you very much. Thank you for what you do as well. So we're rounding up very quickly with the eclectic Mrs. Gua Oriku Redo. Okay, please just say the thank yous to those who have made this possible, particularly our panel and
Yes.
Julie Makani. You must speak.
Okay, I'm going to run through.
This one is to Julie.
Okay. All right. Thank you very much. I've had an excellent time today. Honestly, I thought I knew maybe 60% about sickle cell and everything, but my goodness, I have learned so much today. And I want to start by thanking our most distinguished keynote speaker, Professor Makani, whose delivery was excellent, full of information and data. And most importantly, and I'm sure for everyone, she ended on this note: time to act, enough of talking. Our esteemed panelists, all of whom are achievers in their own right, one of whom is, of course, Her Excellency Dame Edith Okowa, former First Lady of Delta State. Thank you, ma'am, for your excellent work and for really touching on the sickle cell champions themselves in your contributions today. Many thanks also to all our panelists, Professor Lokbade, Professor Ba. In fact, I'm in the midst of so many, oh my God, the amount of knowledge here, all the professors, I feel like, oh my goodness. Professor Lokbade, Professor Swaye, Professor Adekile, Dr. Gaurav, Dr. Wellington, Professor Akinola, Dr. Adesheye, Dr. Lyle Shokwekan, your contributions today have been not only excellent and thought-provoking, and I can distill everything, actually, everything you have said today, I can distill into the following: the political will, enabling environment, patient care and concern, proper preparation, whether setting up the transplant centers, training personnel, handling the risks involved in the new therapies, GVHD, for example, follow-up care. I must not fail to thank Dr. Titilope Fadipe, our moderator of today's panel session. Yes, Dr. Fadipe, you moderated so deftly and wisely and very effectively. Thank you. I know we will reach out to you again. Thank you also to our partners and extended support system, Ministry of Health, Lagos State Government, WHO, everybody, our sponsors and financiers for today, everyone who dialed in, champions, caregivers, researchers, scientists. Thank you all so much. Without you, we would have been talking to ourselves. To our pressmen, thank you for being here and for your support yearly. I must not fail to recognize and thank our national director herself. Yes, you, Annette. Annette, for the awesome work she and her team are doing. You know, I only have one phrase for the dedication, commitment, and tenacity Annette and her team display all the time. And I'd say it is a calling. It's actually a calling, what you do. It is not duty, it is not responsibility, Annette. It is simply a calling and responding to purpose. Well done, Annette and team, for all you do. Incredible work. Well done indeed. Yeah. Let me end this vote of thanks by recognizing and appreciating the esteemed members of the Board of Directors of Sickle Cell Foundation of Nigeria, ably led by our beloved and passionately supportive chairman, Chief Tunde Afolabi, MFR. Thank you all again for an excellent outing this year. And remember, time to act and to talk less. Take care, everybody, and enjoy the rest of the day.
Champions, let me put my picture. The champions, they're not warriors. I don't want you to keep fighting.
Yes, exactly. The champions. Bravo, everyone. Dr. Gaurav, it's great to see you.
Everyone, thank you all.
Thank you. Congratulations.
Thank you. Bye.
Bye.
Well done, everybody. Great outing.
Panelists, we thank you.
Excellent.
Thank you, everybody.
Thank you, and bye for now. Okay, they're showing let me leave it. Other activities coming up. Good.